are by case series, population-based registries and databases. So a meta-analysis of all these and a confirmation of with the
group definitely benefited from adjuvant chemotherapy as compared to observation. So the same group, the aim of this study that they have presented in the abstract form was to evaluate the role of adjuvant chemotherapy as stratified by the EGFR mutation status in patients who had stage 1 lung adenocarcinoma. So again, this was also a retrospective cohort from 2010 to 2016, where they had total of about 1901 patients with stage 1 lung adenocarcinoma as per AJCC 8th edition. And of these, 475 found to have high risk features similar like T1C or T2A lesion or the presence of a lymphovascular invasion. All of these patients had undergone lobectomy. They also did a propensity score analysis, basically to estimate, to adjust for the confounding variables like age, sex, history of smoking, invasive component, tumor size, visceral pleural invasion, lymphatic invasion, vascular invasion. They also looked at the subtype of adenocarcinoma and the EGFR mutation status associated with the administration of adjuvant chemotherapy for matching. The primary endpoint of this study was a 5-year recurrence-free survival. Coming to the results, there were about 475 patients in total. Of this, about 183 were EGFR positive, 292 were either EGFR negative or their EGFR status was unknown. In this group, 36% patients received chemotherapy, 64 did not. In the EGFR positive subgroup, about 42.6% received chemotherapy, 57.4% did not. The propensity analysis for 5-year RFS was done in 80 pairs of patients with EGFR negative or unknown status and 64 pairs for EGFR positive patients. And if you look at the recurrence-free survival in EGFR negative patients or unknown status patients, chemotherapy definitely had an advantage of 5-year RFS of 86.8%. Compared to 70.9% where chemotherapy was not given with a p-value of 0.009. However, in patients who were EGFR positive, the chemotherapy did not make any difference. In fact, the recurrence-free survival was 75.9% versus 79.7%. So the authors have concluded that in high-risk stage 1 lung adenocarcinoma, the results of adjuvant therapy definitely are different as compared, determined by the or stratified by the EGFR mutation status. And EGFR mutation status could be or should be tested in patients who have high risk stage 1 lung adenocarcinoma to help decide what is the role of adjuvant chemotherapy. To my take on this is, obviously this is a retrospective study. Is this a practice changing study? I think we need more prospective trials to reach that conclusion, but this is really a thought-provoking study. Although this is a very small number of patients, we are also looking now at a lot of adjuvant TKIs in patients who are EGFR positive. So is there any role for TKIs in this subset of patients? So these are the questions that remain, I think, in my mind at the end of this study, but certainly a very thought-provoking study. Thank you.
Thank you, Dr. Uma, for excellent presentation. And now coming to the last talk of the session, and I request Dr. Pranjan Basu to present the last presentation for this session.
Hi, good afternoon. Thanks for the invite. So I'll be talking on the effect of post-op RT on 3A to N2 NSCLC after the complete resection and adjuvant chemo. This is a randomized PORT-C clinical trial data. So just to give a bit background information, the PORT meta-analysis first published long back in 1998. We had some survival benefit in the completely resected group, especially the N2 disease, but the RT techniques were quite premature at that time. There were improvement in techniques, and between mid-2000 to the mid-2014-15, few of the articles have highlighted mostly a single center retrospective or small sample size about selected N2 where there is a survival benefit. But the doubt and the queries always remained primarily due to the toxicities and the adverse events. So there are 3 randomized control trials investigating adjuvant RT. One is a CALGB 9734, the lung ARC trial, and this PORT-C. Now Now CalGB 9734 has given 50 gray of port with no difference in DFS and OS. The LungArt, which has published the prelim result, has a statistically non-significant disease-free survival benefit with port. It has not reached statistical significance with about 500 patients, and they have also attributed reduced overall survival, but that might have been due to more of grade 3 to 5 cardiopulmonary serious adverse events. Now this design of the study, which is conducted in National Cancer Center Beijing, has taken histologically confirmed 3A N2 NSCLC, a long time interval between Jan 2009 to December 2017. Patients undergo an adequate surgery first with nodal dissection, followed by platinum doublet 4 cycles adjuvant chemo, and then they are randomized. The radiation dose in post-op adjuvant RT is 50 gray in 25 fractions. Either 3D CRT or IMRT techniques were used, and the target volumes included the ipsilateral hilum, mediastinum, also the subcarinal regions. Radiation should start within 6 weeks from the last chemo, and no interruptions beyond 10 days were allowed. And on the right, these are the dosimetric parameters, as we call it, for the lung and other organs. Now, pre-enrollment, all patients should undergo the routine blood test, a CT thorax with bone scan if PET is not available, also an MR brain, and the standard follow frequencies were followed. The primary endpoint when disease-free survival, which is like date of randomization to disease recurrence or death, whichsoever is earlier, and these are the secondary endpoints, and the adverse events were recorded as for CTCE version 3. So this is the randomization schema, which is more or less well balanced between either of the arms. So this same group from Beijing has actually published their retrospective series about 220 odd patients, and they have shown an improvement in DFS and OS with the port. And mind it, they have used 2D RT also at that time. Not all were, there were no IMRT for that matter. And they've given a sort of a stratification between the groups done surgery, then chemo and radiation. If you look at the median survival time, the 1, 3 and 5 year OS, they were all favoring the addition of port. And that's the primary reason where they have projected this randomized data. So I've done something called modified intention to treat analysis. There are well balanced between the port and the observation group about the numbers. The median DFS was 48 months, and they put a pre-trial set of 230 DFS events to occur at the time of analysis. The median disease-free survival was 22.1 months in port arm with 18.6 in observation. The 3-year disease-free survival was 40.5% to 32.7% in the observation. There were about total 97 deaths. Either of tried treatment failure, be it local, loco-regional or distance, were 226 at the time of analysis. The 3 years local recurrence alone was 9.5% by port to 18.3% by observation as expected. And the distant metastasis between given a local radiation not are similar between either arm, that is also expected. So this is the modified intention to treat analysis Kaplan-Meier curves, and if you see, they have given a modified intention to treat analysis, a per protocol analysis, and at time of analysis depending on what protocol were followed. So in modified intention to treat, only the local recurrence-free survival was statistically significant. However, per protocol analysis wise, the DFS also was significant in the port C data. So there were no grade 4 or 5 adverse events. Even the radiation pneumonitis grade 2 or less, and as well as the esophagitis were seen very few number of patients, and more or less were grade 1. There's only one grade 3 adverse events of one radiation pneumonitis. So what authors have concluded that following the modified intention to treat analysis, there is no improvement in DFS with the addition of port after a complete resection and the complete adjuvant chemo. However, there is improvement of local recurrence-free survival. The adjuvant chemo after optimal surgery remains the standard of care. Port is beneficial in fewer selected groups, few N2s, and further subclassification of studies are required. And this is the strongest point of this study, is that this is the first ever randomized controlled trial of port to complete and conclude the primary endpoint and publish their data. So my take on a SWOT on this study is, this is the biggest strength is it was a phase 3 randomized controlled trial in line with the LungArt trial. It could adhere to the primary endpoint and has an adequate surgery followed by an adjuvant chemo complete cohort as standard of care. Port definitely has improved the local recurrence-free survivals, and it is safe with the improvised radiation techniques. The weakness, the biggest would be, however, poor adherence to the modified intention to treat analysis, a single center study. There were no subclassification between the histological subtype and has a long enrollment phase. So a lot of things have changed beyond 2010, 2015 in lung management. And a nodal yield, this is authors have only concluded, have not been stratified, which becomes significant in one of their publication itself. But this really leads to a lot of window of opportunity of port categorization based on histology and molecular markers, looking at only IMRT or further advanced technique related data instead of a club of 3D and IM and then realizing more of adverse events. We'll wait for other trials, long-term follow-up data. There's one German trial going on which is taking a 7-day RT trial, and people have also tried doing SABR and SBRT in post-op setting. There were true randomized trials going on in New York. The threats are, one should not take into a practice changing, they're relying on a modified intention to treat analysis, and the center should be equipped to manage good salvage options in these local recurrences because they're bound to increase. Thank you.
So thank you, and thanks to the organizers to giving me opportunity, and over to organizers for further proceedings.
Thank you, BK Mishra, sir. Now we'll move on to our next session on panel discussion. As a moderator, I would like to invite Dr. BK Smriti, who is an Honorable Secretary of ISMPO, and she is a Senior Consultant Medical Oncologist from Mumbai. Welcome, madam.
Yeah, good evening, and I'd like to thank the organizers for giving me this opportunity to actually moderate this session, which has brought out many things in the treatment of early stage lung cancer. Can I call upon my panelists, Dr. Rajesh Mistry, surgical oncologist from Mumbai, Dr. Kripa Bajaj, medical oncologist, Dr. Devyani, surgical oncologist, Dr. Ahuja, I'm sorry, but are you a radiotherapist or?
No, ma'am, a radiologist.
Okay. So, Dr. Vipul Doshi, medical oncologist, and Dr. Amrita Athavale, pulmonologist. So, are you all there?
Yes, ma'am. Yes, ma'am. Thank you.
Yeah. To begin, can I share my slides, please? Can you see my slides? Are my slides visible?
Not yet, ma'am.
Not yet.
Now? Are they visible?
Not yet, ma'am.
Ma'am, can we share from the backend team?
Yeah, yeah.
Ma'am, you just have to say next slide.
Yeah, okay. Just a minute, I can't see the slides. Yeah, next slide, please. So the discussion is going to be about the adjuvant TKIs in EGFR mutant non-small cell lung cancer, then the new adjuvant TKI in stage 3 N2 disease, adjuvant immunotherapy in post-surgery patients who have received adjuvant chemotherapy, and of course high-risk stage 1A and port after complete resection and adjuvant chemotherapy. Next slide, please. So coming to this first study, next slide, of adjuvant gefitinib, which was a impact study where gefitinib was compared to cisplatinum and vinorelbine in stage 2-3 lung cancer. Next slide, please. So these were the outcomes that, there was no difference in the survival. And also, if you look at the subgroup analysis, only those patients who are above the age of 70 years showed some benefit and some benefit for deletion 19, but not for the L8 58R mutation. Next slide. So I want to know from the panelists, so can we start with Dr. Vipul Doshi, that do you do EGFR testing in the adjuvant setting?
Yes, madam. We usually do EGFR testing in adjuvant setting, madam.
And do you consider using adjuvant TKI in those patients who are EGFR positive? Given
Yes, madam.
the results from ADORA?
Yes, madam. I would counsel for each and every patient in an adjuvant setting for osimertinib, but hardly only few of them you would be able to take because of the cost issue.
So, I mean, suppose you had a generic, so would you actually give it to all patients with early stage resected EGFR positive lung cancer?
I actually do not prefer using generics, ma'am. If it is,
No, I'm saying if it was available, that's what I said.
I would rather ask them if.
And cost is not a factor.
If it is available and the cost is not a factor, then I would rather use it in adjuvant setting. Yes, ma'am.
But all stage one or only those shown in the ADORA study?
Only those shown in the ADORA study. Stage 1, I am not yet sure.
Okay, now Dr. Kripa Bajaj, why is the ADORA study positive in as far as the disease-free survival is concerned, but the Japanese study is negative? Is there a difference between the two studies?
So not only studies, I think drug efficacy is also quite different, ma'am. Osimertinib is quite efficacious. We have seen all studies, FLORA, FLORA, and any studies in metastatic setting. And ADORA trial, there is significant difference in CNS metastasis-free survival, further recurrence-free survival. So I think it's more of efficacy of the drug, I believe, than the study design or inclusion criteria.
Yeah, so I think that is the most important thing, the drug that has been used. Do you think the use of chemotherapy allowed in the ADORA study, whereas chemotherapy wasn't allowed in the Japanese study in the experimental arm, do you think that made any difference?
So even in ADORA study, 60% received chemotherapy, 40% did not receive chemotherapy. In both arms, there is significant difference in survival is there.
Yes, so that is not the reason. So one of the important reasons is the efficacy of the drug itself, and second most important is the CNS penetration, because in the Japanese study, the CNS relapse was almost 24%, whereas in the ADORA it was just 11%. So there is a large difference. So that also is very important. Now, coming back to Dr. Vipul Doshi, that are there any concerns about the use of adjuvant TKIs in EGFR mutated non-small cell lung cancer? So, do you think there are any concerns about the adjuvant use?
I actually haven't got the consensus in the sense.
You know, you're using the adjuvant TKI, osimertinib. You're going to give it for 3 years.
3 years, yes,
So, are there any reservations or concerns about this use of adjuvant TKI?
Not really.
What about, you know, you don't have the overall survival data, and as you know, the Chinese study was negative. Next slide, please. If you can just show all the adjuvant studies. So, if you look at this, you know, if you look at the Chinese study, they reported no significant overall survival improvement, because those on the placebo arm, when they progressed, they got the TKI, and you know they did just as well. So, do you have concerns? Because after all, the TKIs only delay the progression; they are not, you know, tumoricidal. So, do you have concerns about that?
Can be a possibility, but this the failed trial, the Chinese trial, were using erlotinib or geftinib, and this actually we are talking about osimertinib, which is a better TKI as compared to those.
Yeah. So, Dr. Vipul Doshi, you have to say anything here?
Can I add one thing on this one?
Yes.
So all the trials, like whatever the EGFR mutated beat erlotinib and gefitinib, it hasn't shown any benefit post chemotherapy or like without chemotherapy, not much difference is there. Whoever received chemotherapy compared to this thing. So whoever are not fit for chemotherapy, who are not affordable for osimertinib, I think it's a fair study, fair enough to offer gefitinib. The adjuvant Sitong trials have shown elderly patients, they tolerated well. Whoever cannot tolerate chemotherapy can tolerate TK as well. So in that set, we can offer gefitinib, but not other patients. We can offer EGFR mutated one, erlotinib or gefitinib. But osimertinib scored really big in all aspects compared to these two TKs.
So in our setting where many patients cannot afford adjuvant osimertinib, will you offer gefitinib?
So it's again unfit patient who cannot tolerate cisplatin. So then in that setting, we would like to offer gefitinib, ma'am, but not other people.
Yeah. Next slide, please. So these are all the meta-analysis. And again, in this, there was no overall survival benefit, though progression-free survival benefit was seen. Next slide. Next slide. So now we come to the next study, and that is the, I'm sorry, I'm not able to involve the surgeons and the radiologists and pulmonologists as yet, but I would be involving them later. So if you come to the EMPOWER study, where atezolizumab was given as adjuvant therapy after completely resected stage 3 and who had received adjuvant chemo. So I would just like to ask Dr. Rajesh Mistry, how do you deal with very shortly, briefly, stage 3A lung cancer, 3A and 3B? How do you decide the resectability? Dr. Rajesh Mistry? Is he there? Or Dr. Devyani?
Yeah, hi, madam. So for 3A lung cancer, which would be single station N2, I think during the mediastinoscopy itself, we try and see whether we can get an R0 resection at the node. So only if it is single station resectable N2 disease would we think of surgery in this population. If it is multi-station N2 or if it is unresectable, that is, there's no strict say 3 centimeters, but if it's unresectable N2 or obviously N3 disease, then it goes beyond the scope of surgery into the realm of chemotherapy and radiation.
Yeah, and of course, here they had not mentioned what is the staging that they did for the mediastinum, but right. Dr. Ahuja, I'd just like to bring you in here. What are the results of mediastinal staging with, PET CT, and would you like to confirm, Dr. Devyani, with either mediastinoscopy or EBUS?
Yes, ma'am, definitely. So PET CT along with CT provides good enough sensitivity and specificity, but I think if you're going to operate the patient, then a mediastinoscopy to confirm is mandatory, is required.
Dr. Rajesh Mistry would like to say something. Are you there? Okay, so then, next slide, please. So I'd like to come back to the medical oncologist, Dr. Vipul Doshi. Which patient in this study showed a significant disease-free survival benefit? Can you just tell us that?
When the PD-L1 positivity score was more than 1% and even better if it is more than 50%, those scored better DFS as compared to the chemotherapy alone.
Yes, but of course, it was stage 2 to 3A. I mean, in that particular thing, the 1B was not included. So I think that has to be kept in mind. And Dr. Kripa Bajaj?
Yes, ma'am.
Who showed this significant disease-free survival benefit?
All comers are like more than PD-L1 positive, both showed benefit, but the significant benefit is seen in more than 1% people and quite significant in more than 50% people, ma'am. From stage 2 to stage 3, like they were included patients were there. So all showed benefit, but significant in more than 1%.
Okay. So would you now, do you know whether this is included now in the NCCN guidelines?
No, we actually have to wait for the OS data, but we can offer the data is there, but it's too early to include.
Yeah, but if you look at the 2022 version, then this has been included in the adjuvant setting. So they have not yet waited for the overall survival data. Now, if you were to do the PDL1 testing, by which method would you do it according to this study? Because they did modify the testing method in between.
SP263 is the ideal, ma'am. Like I'll go by that antibody.
And do you think the safety profile is acceptable?
Yes, ma'am, it's quite acceptable. It's like any other immunotherapy profile, so it's acceptable.
Yeah, there was some increase in the liver enzymes and all, but all these toxicities we are able to deal with. I'd just like to ask Dr. Amrita Athavale, have you come across cases of, lung toxicity due to either the TKIs or the immunotherapy? Have they come to you, or your medical oncologists have taken your help in this regard? Dr. Amrita Athavale, is she there? Okay, so then now would you consider PDL1 testing in stage 1B here?
No, ma'am, 1B, not it. So from stage 2 is the inclusion, so from there only I'll start, not 1B.
Yes. So in the conclusions, it was clearly stated it was PDL1 positive stage 2 and stage 3 that benefited. Next slide, please. So this is what, and it was shown by the previous speaker. So I won't dwell much on this, just to show that all patients benefited in the subgroups which are PDL1 positive. Next slide. Now stage 1 and adjuvant therapy. Next slide. So what criteria do you use to offer adjuvant therapy in stage 1? So can you tell me, Dr. Kripa Bajaj?
More than 4 centimeter will definitely include, ma'am. And LVSA is a very soft indication for us. But more than 4 centimeters, definitely yes.
And what about lymphovascular emboli?
Yeah, ma'am. LV is a soft indication. There is a controversy there around it.
Yeah.
But more than 4 centimeters, strongly yes. LVSI, it depends on institution to institution. I would like to add only if it is more than 4 centimeters. LV is really soft indication.
And Dr. Vipul Doshi?
Yeah, I agree with Dr. Kripa said. If
Yeah.
it's more than 4 centimeters, then I'll definitely push for it.
Yeah.
LVSA is a soft indicator.
Yeah, next slide. So this was the study shown by Dr. Uma, and EGFR status seemed to influence the outcome of chemotherapy. Would you accept this data and use EGFR to decide on chemotherapy? Dr. Vipul Doshi?
Actually, this is a retrospective data,
Right.
and I would wait for more data to
Right.
decide on EGFR positive or negative to
Yeah.
choose the chemotherapy. I would rather
Yeah.
use age-old, like more than 4 centimeters and other risk factors to decide
Yeah.
on it.
Yeah, next slide. So these are the NCCN guidelines, and as you can see that both osimertinib as well as atezolizumab has made its way here into the adjuvant setting. Now I would like to ask Dr. Vipul Doshi, you have the 816 which checkmate 816 where nivolumab with chemotherapy has shown good results in the neoadjuvant therapy. So if you were to use that in future, whenever you had the, it was included in the guidelines, then definitely you would have problems in using it in the adjuvant setting, right? Dr. Vipul Doshi?
I'm not able to comment on that. Maybe Kripa can take it.
Okay. Next slide, please. So now coming to, we can slip this slide because, yeah. So this was the fourth study, and this is regarding stage 3A and 2 adenocarcinoma. I want to know, have you used TKIs as the EGFR? Have you used TKIs in the neoadjuvant setting? Dr. Kripa Bajaj?
No, ma'am, I never tried TKS in neoadjuvant setting. Have never tried it.
Yeah. So I think for shortage of time, because the last study is very important. Can you go to the next slide? So this was the emerging study again from the Chinese. It was a phase 2. And of course, it did not reach the level of significance in overall survival, though they had shown an improvement in the progression-free survival, which was submitted 2 years back at the ESMO 2019. And the reason they gave was whatever the post-hoc analysis, subsequent treatments did very well. So I think you're right. I don't want to dwell on this study because it's still in the experimental phase, the use of neoadjuvant TKIs. Next slide. Now coming to the most important, one of the most important is the use of radiotherapy in those patients who are resected stage 2, stage 3A and 2 positive. Now, Dr. Devyani, you've resected the patient and you have given, the medical oncologist has given chemotherapy. So would you be referring any patients for radiotherapy?
Thank you, ma'am. So as per the latest data from the LUNGAT and the POTC, even in our institution, we have stopped giving adjuvant radiation for patients with persistent N2 post chemotherapy. But having said that, I think it was very well illustrated in the last talk that probably there is still a subset of individuals who might benefit from adjuvant RT. So I would definitely check with the operating surgeon whether they were very comfortable with the R0 resection status that they achieved at the lymph nodes. And if there is any doubt regarding the R0 resection at the lymph nodes, then I think post-op radiation would still at least deserve a referral.
So how do you want the pathologist to report on the nodal stations? Like, are the stations important or the number of lymph nodes dissected are important? What is important?
I think both are important, but the stations would be predominantly important because as we know, single station versus multi-station N2 changes the prognosis quite dramatically. And also, if we look at the study now that even the POTC, that more number of positive lymph nodes again becomes one of those subsets which are veering towards benefit with post-op radiation. So I think they would need to report both.
Yeah. So Dr. Rajesh Mistry there. Am I running out of time?
4 minutes left, ma'am.
Yeah. So Dr. Rajesh Mistry, are you there? Is Dr. Rajesh Mistry there? Okay. So Dr. Devyani, what sort of mediastinal nodal dissection do you do, and when sending the specimen to the pathologist, because you said the stations are important. So what are the things to be looked at when you send the specimen?
Right. So generally, we start with a mediastinoscopy, especially if there is any chance that this patient is going to be a stage 3A. And during a video mediastinoscopy, we address both the right and the left paratracheal nodes at level 2 and 4, as well as the subcarinal lymph nodes. And we send them in separate packets for frozen section analysis. If any one of them comes positive, we prefer to give neoadjuvant chemotherapy to these patients. Now, if we operate a patient post-neoadjuvant chemotherapy, we go ahead with a systematic mediastinal lymph node dissection. So, whether it is a left-sided lung dissection or a right-sided, the stations that we do clear are the upper and lower paratracheal, that's 2 and 4. Station 7, that is the subcarinal lymph node station. The station 8 along the paraesophageal and the inferior pulmonary ligament nodes. Left-sided resections, we also clear the prevascular and the AP window nodes. And all these nodes are sent separately in separate packets for histological examination.
Well, we don't have a radiotherapist in the panel, so we're missing a radiotherapist. Would you want the radiotherapist to give radiation? If
Madam, Tiranjan will be there. He can take the question if you want.
Who, doctor?
Dr. Basu is there? Tiranjan Basu?
Is he there? Because he is not mentioned in the panel.
He's not in the panel, but we just thought we can co-opt.
Can I have his opinion on this? That if there are 6 to 8, there is some emerging data about the benefit of radiation if there were more than 6 to 8 nodes positive. Dr. Chiranjan?
Nilanjan.
Yeah, Nilanjan. Sorry. Yeah.
If more than heavy nodal burden, there are some data like you rightly said. Even the one I presented in that also, the same group from Beijing have done one analysis on number of node positivity, number of node dissected, number of positive to the number of node dissected. So more the nodal yield, yes, there are sub cohort where it has a local recurrence free survival benefit with port.
Yeah. So what about extranodal extension? Is that a criteria?
Not really for radiation in lung like other
Okay.
states.
Okay. No, just to make it clear, where you would consider, given the negative results from all these studies. Next slide. Yeah. So now the thing that was brought out was, if you look at all the three studies, one of the main deficiencies were, it is a very long period of accrual when many things have changed in the radiotherapy field as well as the the systemic therapy. And if you look at it, as it was shown in the presentation, that the local recurrence-free survival was significantly improved, and the deficiency was actually because of the distant metastasis, which could not be reduced by giving the local therapies. But now with the improved systemic therapies, so again, coming back to the radiotherapists, do you think that this should be revisited because of its effect on local recurrence?
So traditionally, ma'am, the role of radiation is always to prevent local recurrence. Of course, the more the local recurrence can be reduced, it definitely translates into OS benefit. So it should be revisited. Yeah, I would definitely say as radiation oncology.
Yeah, because now you have, the therapies, systemic therapies used during those studies, it ended in 2017. So you didn't have, osimertinib and drugs like that. So, now you have much better systemic therapies. So I think, so is there any trial in the offing now to relook at this?
When I checked about the post of adjuvant RT data, there are a couple of about 10-15 trials going on across the globe on these molecular classification and adding whatever may be EGFR TKIs with also after the completion of adjuvant chemo and with port. So all will take at least 3 to 4 years to complete, and then we'll have some data.
And in case you do give port, then in some select patients, what's the dose and what are the toxicity concerns?
With IMRT, even the IMRT 3DCRT combined port C, that is the only randomized data published, has actually none of grade 3 toxicity. Even the grade 2 is less. So the grade 1, which is like mild cough maybe from pneumonitis aspect and mild to moderate dysphagia with grade 2 esophagitis, would be around 15% or so, even less than that. And if it is sole IMRT, then it will be further reduced, I presume or believe. And the dose should not be more than 54, because people have tried dose escalation in port and which has detrimental outcome. So the dose should be between, it will be 50 gray equivalent. People do it 1.8 gray, people do it 2 gray. So it will be 50 gray equivalent, and that is good enough. The important is to choose the right technique, which should be IMRT in today's time, and even with some sort of image guidance for sure, so that to reduce the normal lung volume receiving radiation, and also
Madam,
to follow standard guidelines.
Yeah. So the last question, that is for Dr. Ahuja. So are you involved with doing the scans for the treatment planning, Dr. Ahuja?
Yes, ma'am. So we are involved with the planning and what marking of the lesions properly, so that the radiation can be well given.
Yeah. So I think I've come to the end of my panel discussion. Well, I'd again like to thank the organizers and the panelists for this panel discussion, and I hope there have been some take-home messages, especially that the use of adjuvant osimertinib has come in 1B to 3 stage. When it comes to adjuvant immune checkpoint inhibitor, atezolizumab has received the approval as adjuvant therapy for PD-L1 positive, stage 2 and stage 3. Neoadjuvant TKIs do not have a role at the moment. and very limited selected patients would consider port, but otherwise it has shown no survival benefit. Thank you.
Thank you, ma'am. Now we'll move on our next session. I will like to invite Dr. Suresh Advani, sir, who is a very senior oncologist, to chairperson our next session.
Yeah, good evening, colleagues. First of all, let me thank the organizers for giving me this opportunity to chair this session. As all of you know, that how the landscape of treatment of lung cancer has undergone revolution from chemotherapy to targeted therapy and immunotherapy. And we have so many options. And that's where even immunotherapy by itself is undergoing the evolution. Initially, we started using it after the failure of the chemotherapy and target therapy. And now it is probably going to come up as a frontline treatment also in the non-small cell metastatic lung cancer. And I think that's where the role of the atezolizumab is becoming very important, that we have been using it as a treatment for the second line, but now as a monotherapy upfront in the naive patient, treatment naive patient, also becoming the reality. And today we have with us Dr. Ashish Singh, who is going to tell us about the role of atezolizumab monotherapy in metastatic non-small cell lung cancer with PD-L1 positivity. Dr. Ashish Singh.
Thank you, Advani sir. Good evening, everyone. Thank you, Kumar sir and Vijay, for organizing this, I would say, mammoth meeting. This is not an easy task, and you do it year after year, and this is the place to be if you want to know what's latest and trending in lung cancer. So for this Roche sponsored symposium, my task today is to take you through the data regarding use of checkpoint inhibitor, particularly atezolizumab, in a biomarker defined population which is high PD-L1 expressing group. Now, everyone who treats lung cancer, we know that it's such a difficult to treat disease. We have made advances in driver mutation positive disease, but that's only a subset, predominantly EGFR, ALK mutated patients. Even though we do find other targetable mutations, however, still we have not yet seen data that targeted therapy, like for example for a KRAS or for a PIK3CA or even for a HER2, is probably better than chemo or chemoimmunotherapy, especially if they express PD-L1, which in itself is a biomarker, not a perfect biomarker, but but we all have to learn how do we use it. And so today we talk about using atezolizumab, and all of you in the room know that we have 3 large randomized global phase 3 trials which has shown us the efficacy of this drug. The first one, IMpower 110, which we predominantly will discuss today, was looking at atezo versus chemo alone. The second one, IMpower 130, looked at chemo atezo versus chemo. And then the last one, IMpower 150, looked at chemo compared to chemo atezo with or without bevacizumab. There's a third arm to that. Now, so looking the schema of this trial, again, it's a global randomized phase 3 trial. These are all patients who have not had any treatment. They had to be negative for EGFR and ALK. Other mutations we don't know. And the stratification was based on PD-L1 IHC, which was done by SP142 in this study. It was 1:1 randomization. Chemotherapy was standard. For adeno, we gave pemetrexed, and for squamous, we gave gemcitabine. And atezo was 1,200 milligram flat dose every 3 weekly till progression. Primary endpoint, overall survival, and secondary endpoint were other things like PFS and duration of response. Now, the statistics of this study, they like in some of the studies we are seeing now, they use this what we call hierarchical testing design. That means in the analysis plan they wrote that they will initially look only at high expressors, that is PD-L1 more than, that is in this antibody is defined as TC3 or IC3, that is basically tumor cells more than 50% or immune cells more than 10%. If that is positive, the analysis will move on and include the lesser expressors that would be like 1 to 50%, and then if that is positive, they will move on and look at the overall study, which is any expression. Now, it was a stratification factor, so we need to see whether randomization worked well. But if you see here that there was no imbalances between the number of positive patients, and if you see about 35%, that's 1/3 of these were high expressors, and that is about total sample size of about 200 odd patients. Now, the kind of patients who went into this study, half of them were more than 65, so the little older population, and most of them had used tobacco. Only about 10 to 15% did not have any history of tobacco use, and most of them, like 70%, were adenocarcinomas, and most of them were in good performance state. No, not most were good performance stages. The PS0 was only about 1/3. So this is the primary endpoint in the first testing, hierarchical testing, where you looked at overall survival in very high expressors, TC3 or IC3, and you clearly see the curves are separating after about 6 months. And if you look at the landmark, that is about 6 months and 12 months. So let's just look at the 12 months, 50% versus 60%. And this is not progression free, this is overall survival. So 1 out of 2 patients are dead if they started on chemotherapy, as compared to about 65% of patients who were alive. And the hazard ratio of 0.5. Now these data is updated now after publication in NEJM. And if you see ones with a longer follow-up, again you see almost from 14.7 months median, the overall survival improved to 20, and your hazard ratio is 0.76. The absolute difference at 1 year is still about 15% in number of patients who are alive. Forest plot, if you look at it, except for this never used tobacco, maybe they had some underlying mutated disease. We don't know, numbers are too small for us to draw any conclusion, but what it shows is that majority of, if you look at across factors, they all seems to benefit. Now when you talk about overall survival, very important to see whether what proportion of patients had immunotherapy in their subsequent lines, especially the ones who did not get it upfront. So if you see here, only about 50% of patients could receive second line therapy, of which about 34 was immunotherapy. So that is a big problem. We all know in lung cancer, patients are not fit as you go to second line. So keeping something for second line may not be a good option, but at least it's good that in this study, at least 1 out of 3 patients did see immunotherapy, and the results we see is in spite of those patients who received immunotherapy. Now, if you tell the statistician, they'll do some adjustment, and when they adjusted for patients who would have not, if all would have not got immunotherapy, the hazard ratio they're projecting is about 0.69. So now when we move to the second subgroup, that was in TC2, that is a little lesser expression, we see that still numerically there is a difference. 14.9 improves to 18 months median, but this doesn't reach statistical significance. So because of this, we cannot kind of keep doing analysis in subsequently, like for PFS and for all expressors. This is for all expressors, that is TC1, 2 or 3. Here if you see, the 12-month overall survival is 54 versus 57%. So basically what we realize from this study and this randomized data, that if you are high expressors, that is where immunotherapy upfront will give you better survival, and for all the other patients it may not be a good idea to reserve chemotherapy for later use. You may have to use chemoimmunotherapy upfront. And PFS, again, if you see, there's 12-month PFS is almost double here to 19 months versus 39.2 months. And now if you look at duration of response, now if you look at response per se, 30% chemo with chemotherapy and 40% with immunotherapy, but what you have to look at is the median duration of response. So we all know chemotherapy responses don't last very long. The moment you do your next scan, the median is here 6 months here. They have progressed. But if you have responded to immunotherapy, the median duration of response is pretty good. That's 26 months in this study. So that's again, which is reassuring to see. Now side effects, we all know chemotherapy side effects, and we all know immunotherapy side effects. So immunotherapy is not without side effects. What you need to remember is these 10% of patients who would get side effects. And if you look at the number of patients who use steroids, 13%. Number of patients where the treatment was withdrawn due to an AI was about 7%. So that's the 7-10% patients which we cannot miss in our practice, and we need to look at liver functions and thyroid abnormalities, colitis, and on those things. So based on these data, even the regulatory authorities have allowed usage of single agent atezolizumab in PD-L1 high expressors, that is more than 50%, or immune cells more than 10% if you're using the SP142 antibodies. Even the ESMO guidelines puts it as a category 1 recommendation. What I didn't show you a slide, but what I want to tell you is in the same study, in an exploratory analysis, they also looked at concordance between SP263 and 22C3, and they showed that TC3 and IC3 actually correlates, the curves look exactly similar in all the 3 slides. So in conclusion, this is a positive study which has led to regulatory approvals. And if we have a patient, we are not in an urgent need for disease control, patient is in good performance status, we can kind of give him a chemotherapy-free treatment upfront, and if he responds, the duration of response is pretty good, and we know that these patients actually survive longer because you're treating everybody upfront and not reserving something any important treatment like immunotherapy for later lines. And this treatment is well tolerated, and this should be this is a good treatment option for all our patients. Thank you.
For next, to continue, I'd like to invite Dr. Minish Jain, who is a senior oncologist from Pune, to call other panelists for the next panel discussion session.
Good evening. Hi, I'm Dr. Minish Jain. My panel people will be Dr. Kumar Prabhash from Mumbai, Dr. Ashish Joshi from Mumbai, Dr. Kaushal Patel from Surat, Dr. Amit Joshi from Mumbai, Dr. Dattatreya from Hyderabad, and Dr. Ajit from Delhi. Hello, everyone. Can we have the first slide? Okay. So we will be discussing role of atezolizumab monotherapy in first-line setting, and we have already seen Dr. Ashish Singh presenting to us the data which is available. Targeted therapies, we all know, have improved the survival in non-small cell lung cancer, and there is an unmet need for this kind of treatment in patients who have no actionable biomarker, and PD-L1 positivity is now becoming a significant mark. First slide. So my question to Dr. Kumar is, what is your treatment of choice in patients with no actionable driver mutation? Dr. Kumar?
So if you don't have a driver mutation, and then if you do have...
Dr. Ashish, anybody?
Can you hear me? Dr. Jain, can you hear me?
Yeah.
Sorry, I think so. There was an issue regarding a speaker. So if the mutations are negative, then PD-L1 expression becomes important biomarker to decide a first-line treatment. If it is high, we take a cutoff of 50%, but that's one of the cutoff we take it. It is high, then giving immunotherapy alone is something we choose. In case we also look for how is the tumor burden. If it is high, again that becomes one of those relative important factor. We again choose whom to give them only single agent immunotherapy or to combine. But below 50%, by and large, we combine with chemotherapy in this setting. And yes, we do have this again other option of combining with VEGF inhibitor also with chemotherapy and immunotherapy. But by and large, we don't use them so commonly. But this is the overall schema of things in case if the patient can afford all the options available.
If there are no mutations, do you use only immunotherapy in those kind of patients?
Yes, if I have a PD-L1 expression of more than 50% and tumor volume being
No PDL1. It's PDL1 0.
Oh, then also yes, I do. I do use, I give that option, but telling the patients that the chances of benefit what he's going to get with them is going to be low. And if they understand that and they're willing, then yes, we do combine, that with, chemotherapy.
No, means nivolumab, ipilimumab.
Yes, that's a very important discussion, sir, you are bringing up. And that is one of those combination where you have more subgroup analysis, which suggests that if you have a PD-L1 expression which is low or negative, and that combination shows a bit more benefit than what we have seen otherwise with immunotherapy alone. But we do also have data for Keynote 189 that combining with chemotherapy also gives good result. But having said that, I do agree, if I have to tease it and then place this combination somewhere, this is one place where one can use this combination in that setting. So there is a merit to it, what you suggested, Dr. Jain.
Okay, can we have the next slide, please? Dr. Ashish, what are your, how do you choose, means whether you're going to do which platform investigations, like whether you will be doing an SP142, you will be doing a 22C3, or you will be doing a SP263, or you will be sending it for Foundation 1, or you will be doing selective markers. What are your parameters? Like, how do you choose?
So typically, sir, I prefer to go for a broad based NGS based testing. But we obviously understand that there are limitations sometimes in terms of the finances. So then limited lung cancer panel also is often, that is the bare minimum that I do for all my patients. And PD-L1 usually is SP263 is the marker which is commonly done in the laboratories where we are associated with. So that's what practically happens. We obviously know that there are companion biomarkers for each drug, but that is typically what is not practiced in a community oncology. And usually SP263 is the one which rules the roost.
Okay. Dr. Rajit, anything different at your place?
So for practical reasons, it is all the same. But if we know that we are going to plan a particular IO drug, then it's better that if it's possible, we do use that platform. But if we are not sure, or we can use the platform interchangeably, but if we know that we are going to plan this particular regimen, then it's better to specify the type of PD-L1 test.
It becomes very difficult what we are going to use. It all depends on, after the reports come, then we start thinking what we are going to use. So
Correct.
This is the biggest trouble with us. Like, we order, we get, and then we start deciding. So we're not decided with what you are going to do. And that is
not in that way. Suppose we have the NGS report with us and that is showing no mutation, then we can decide whether we want to, what type of platform do we want to do. So if we have the NGS report with us, then we can separately order the PD-L1.
Do you consider TMB as an important marker for considering immunotherapy?
So it is an important marker, but as of now, I don't think that it should be used in clinical practice because the data is still evolving, and at least most of the clinicians, they are not comfortable using IO with the TMB report. So I don't think that it should be used as of now for deciding the treatment.
Yeah, I agree. The rule is very uncertain right now, though it may indicate in certain things we are taking it up, but for lung cancer, we should restrict ourselves. Next slide. Basically, if you look at all these are the markers available to us, but what we are using today is the PD-L1 expression either on the tumor or the tumor microenvironment or the immune cells. So this is the only thing which is really helping us. We are not sure. Dr. Ashish, do you consider age as a factor for immunotherapy consideration?
Not really, sir. I think immunotherapy is something which is a pervasive and it probably could be given across the subgroup of patients. So, in fact, sometimes there are old moribund patients where chemotherapy may not be an option. That time, in fact, monotherapy with immuno, especially with the PD-L1 positivity, could be a decent option. So, age is not a consideration for doing the biomarker analysis. And irrespective of the age, I think we all nowadays in our clinics do at least basic biomarker analysis, which is limited lung cancer panel with PDL1 testing.
Dr. Kaushal, do you think that your patients with smoking history, non-smoking history matters when it comes to immunotherapy?
Good evening. As of now, actually, we can consider IO in both the cases, either it's a smoker or non-smoker. I don't think so if there is any difference of the result point of view. So we can use it in either of the cases.
No, we can use it, but the results just presented by Ashish also showed that if patients are more than age 75, or if they are non-smoker, non-tobacco chewer, or non-tobacco users, then they were not good on the forest flood. They were actually falling on the other side towards the chemotherapy. So, Dr. Ashish Singh, do you want to add to this what you presented?
Sir, I think I'll agree with both of you. I mean, but what I would want is a little broader NGS panel in people who are younger and who are non-smokers, just so that I'm not missing maybe a better option. But if I have done a good NGS and PDL1 positive, just because he is not a smoker would not stop me from using this option.
Means, would you consider them for chemoimmunotherapy rather than immunotherapy alone? That is what is my next question.
Yes, sir. So adding chemo, whatever trial we have seen has definitely helped. In this more than 50%, we don't have data yet of chemo-immuno better than immuno alone. But but like as Dr. Kumar sir also was said, high disease burden, symptomatic patients, even the 9-LA like regimen, only 2 chemo and then stop the chemo after a response is a good option.
Okay, next slide. So my question to Dr. Dattatreya, if there is a PDL1 high expression more than 50% in any of the tests, whichever is available, would you consider single agent immunotherapy or a combination with chemotherapy or only chemotherapy?
Without any doubt, sir, I would go with the first option of using a single agent immuno-oncology molecule. My practice more has been towards pembrolizumab, but having said that, I'm completely okay with atezolizumab also. So single agent IO is my treatment of choice when the PDL1 is high.
Okay, let's see the data, what comes up. Next slide. Next, can we have the next slide? So cancer immunotherapy offers a chemotherapy-free option to patients with non-small cell lung cancer. It provides treatment which is having an increased survival, reduced therapy-related toxicity when compared to standard of care. And this is something which is, we have already seen that there is a 7 months advantage in this kind of patients. Next slide. So we have 4 trials which have shown that there is an improvement. The IM Power 110, the Keynote 024, the Keynote 042, and the M-Power, the drug which is not available to us right now, Semiplib. So Semilimab, which is not available to us as of now. So let's look at these 4 which are actually the positive trials in this monotherapy cancer immunotherapy. Next slide. We have already seen this data from Dr. Ashish Singh, so we can go to the next slide. So there is a 7 months advantage, hazard ratio being 0.59 in this kind of group of atezolizumab, and definitely patients doing well even after 20 months. So you continue to see the graph moving away. Next slide. Yeah. Next. Next. Okay. This is what I was trying to say, that if they have never used tobacco, then these are the patients who actually fall on towards the chemotherapy side. And if they are older patients, their hazard ratio was 1.04. So if you have an older patient, immunotherapy probably was not doing well for them. So rest everybody favored the immunotherapy arm. Next. Next. Okay. So This is already discussed. There was a meaningful improvement in PFS in patients with atezolizumab, and this was definitely for the arms which were like hazard ratio was 0.63. The 12 months and 6 months both were improved progression-free survival in this particular arm. But this was not the primary thing when we were looking at the study. Next slide. Now my question to Dr. Kumar is like, what is the platform you are using at TMH? SP263, SP142, or you are using any of those?
Sir, we are using SP263 at this moment.
Okay. Okay. Is there a benefit of 142 compared to 263 because it will give you both the tumor as well as the immune cell expression?
I think so. You can have all the platform. We have not been able to get DACO, sir. So that's a challenge, that having all the antibodies, and so ultimately we end up having in most of the lab single antibody and single platform, and then we try to see how concordance rate has been, and that's what I think so. Ashish also tried to bring up that there is a good concordance, and before that there has been two study, not as a part of a randomized trial, as a part of study to see those different antibody and how they correlate good to each other, and looks like they correlate fairly well. Having said that, except SP142, which was an outlier, others they correlated very well to each other, and one can, again I repeat, I say that it can use it interchangeably. But having said that, if we have we can have a moon on my plate, I like to have it, but otherwise I will go by what is available. That is, I have a SP263, and I'll try to compare with this data what is available and use it in the clinic. And we do use it, not for this drug. Before that, we have been using a single agent immunotherapy based on the data available with SP263.
See, the thing is that if you have an high expression, whether it is with SP142, 22C3 or SP263, in all those cases, the outcome with atezolizumab when they compared was good. It was 20 months, 19.5 months, or 20.2 months. So it was doing well, and all those things had a concurrence. So if you have a high expression, atezolizumab can be used. When the expression is low, the difference is quite significant. So if you are using a single agent atezolizumab in a low expression, you may have to do an SP142 to find out if there are select patients who may be expressing on immune cells. So if it is high, and then there is no problem. If it is low, do not use interchangeably. If it is high, you can use it interchangeably. There is no problem. And almost 30% patients may fall apart. So there is a big number which actually falls apart. So only in high you can use it. In low, do not use it. That's my suggestion. But anyway, we can take from the house if anybody has any different suggestions. Dr. Kaushal, Dr. Ashish, if you have anything to suggest, we can.
Can I make a quick comment, sir?
Dr. Manish Jain, on one comment. Only thing is that it's not the question. The only problem will be the PAP program, what the company wants. So that is going to be the most difficult thing to. So if you have done a SP2 to the pembrolizumab for, then can we use that for that, or vice versa? If you are going for atezolizumab, and then usually the 142 people can't usually do not use that. So if it is been done from 2 to 3, whether that can be applicable for that or not. So that is going to be the question from the company side. If they are comfortable with that, and I think if there is a pathologist there is one of the study which is not a blueprint study, blueprint 2, that compared that SP223 and DACO kit. They have a good concurrence between these two, but 142 and the other have not a very good concurrence. So the 223 and the DACO kit has a good concurrence from that point of view.
No, I agree. That's what I'm saying. If there is a high expression, atezolizumab can be used at par. the outcome is same for all the three tests. But if it is not very high, not more than 50%, then do not use atezolizumab in those lower patients. So you may have to do an SP142 if you are specifically looking for atezolizumab. That's what I'm trying to say. Next slide.
So can I make a quick comment, sir?
Yeah, please.
So just coming back to the same question about monotherapy in first line, and we have all discussed about the discordance and concordance of the PD-L1 as a biomarker. Somehow in my clinic, I tend to use, even if for a high expressing PD-L1, I tend to use combo of chemo and immuno to start with, especially in a symptomatic patient, and then get the chemo out and then probably continue with IO.
No, there is nothing wrong. See, this is all about personal choices. So you can decide if that is comfortable for you and your patient is fit, why not? You are actually creating more antigenicity. So I agree. If the patient can tolerate it, you can go ahead. There's no such thing that you cannot use it. There are so many choices now.
Yes, sir.
Sir, there is one more thing that I would like to add. So in all these graphs, you can see that the curve separates after 4 to 6 months. So even if PD-L1 is more than 50%, I also think that the more rational combination is adding chemo plus IO. So that covers all the problem regarding the PD-L1 platform, regarding the age, regarding patient is smoker or non-smoker. And so that is a more rational approach for me also.
See, we are moving from gunshot to the more targeted. So that is a gunshot. You can take everything under it. You can give ABCP also then. So that's not an issue. When you have highly select population and if you have selected it rightly, even a single agent can do magic. So you do not require too many agents to create a magic. So you need to really know that your patient is a tobacco user or not. That indicates that the tumor mutational burden is going to be high. Okay. So if a patient is non-smoker or non-this thing, there may be some mutations which have been missed.
Like the magic can happen after 2 to 3 months also. So if we
KRAS.
if we give chemotherapy, then after that magic can also happen.
No, that's true. But there can be other factors. KRAS can be there. There can be some which we may have missed out. So that may be the reason why patients do not respond. And they may be responding to your paclitaxel. KRAS may be working well with paclitaxel.
I think so. Organizers are getting a bit restless for timing.
Okay. I think we will go to the next slide. Okay, I just want to quickly come on to next. Can we skip this? We have already discussed this. I just want to highlight on one thing. When we compare IM power 110, the 024 and 042, the next slide. IM power 110 was standing out through the meta-analysis of network meta-analysis, and the thing was IM power 110 was having both squamous as well as adeno. It had some Asian population which was around 19%. The keynote 024 had 97%. So if you look at Asian kind of patients with liver metastasis, which was not included in 024, which was not included in 042. So if you have liver mets, if you have Asian, if your tobacco exposure is there or not there, if you are squamous or non-squamous, then, and if you look at the network meta-analysis of toxicity ratio, atezolizumab, we do not have time to cover up all those things, but then in those situations we find that this drug is coming out quite good. Next few slides we can just go through it quickly. Next. So this is something which we were discussing. The liver mets were not included in this. So the outcome was good in 0 to 4 because these patients had all high expression, male, more exposure of tobacco, which was less here, and liver mets were not there. Next slide. Next, we can skip this. Next, and this was the meta-analysis, which was showing that atezolizumab was significantly better. Cemiplimab was also good, but the toxicity of immune responses was very high in this particular population. Next slide. This drug is not available with us, but then if you look at the immune-related reactions to this drug, which was very high. compared to atezolizumab, which was favoring into this meta-analysis. Next slide. See this, if you look at this right side, it is the immune-related adverse events which were high in this particular study or the semiplimab study. Otherwise, the drug was good. Atezolizumab was falling onto every time on the better side. Thank you. I think we have covered most of the points. If there are any questions from any of the participants, we can take that. Any questions? Then we'll close the discussion here. Thank you, Dr.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you.
Good evening, everyone. So we will be moving to our next session, which is a case-based panel discussion on the management of early-stage lung cancer. I would like to invite Dr. Shyam Agrawal. He is a senior-most medical oncologist from Delhi to moderate the session.
So, thank you very much to the organizers for inviting me to have this panel discussion, which is a case-based panel discussion. And I think the technical staff has the presentation. Yeah. So I think in the panel, we have three medical oncologists, Dr. Chakor, Dr. Kaushal, and Dr. Taha. And there are two surgical oncologists, Dr. Robin and Dr. Priya.
Sir, may I interrupt? Dr. Taha is not there, so Dr. Ashish Singh from Mumbai will be joining us for the panel discussion.
Great. Thank you. Thank you very much. So welcome to all for this interactive session. Kindly feel free to interrupt because the idea is to, have a discussion on early stage lung cancer. So can I have the next slide, please? So this is a 67-year-old gentleman who is a non-smoker who has presented with mild cough, and there is a small lesion seen on a chest X-ray in the left upper lobe, and the CT scan of the chest shows a lesion in the same area. Next slide. Okay, so you can appreciate the nodular lesion in the left upper lobe on the CT scan, and on the PET CT scan, which is lighting up quite well here. And you can't see, much in terms of the node in the hilar or in the mediastinal region. Can I have the next slide? So I think this is the summary of the findings there, that there is no metastasis anywhere in the body. And that is the finding of the PET CT scan, that you only see the left upper lobe region with some adjacent pleural tabs. Next slide. So the question to the medical oncologist, to Dr. Chakor maybe. So CT guided biopsy possible, and comments on tissue quantity, which also enables molecular testing. So can Dr. Chakor, so what would be your approach in this patient where the tumor is located, in the upper lobe? So how would you, if the patient comes to you, what would be your, suggestion or advice to the patient?
So, sir, the first thing will be, yes, CT guided biopsy can be taken, and adequacy of the tissue can be tested at the same time when the biopsy is being taken. And resectability, we can, but it looks resectable, but obviously a surgeon will take the call on that. And definitely they will have to do mediastinal staging to once confirm that the mediastinal disease is not there. But it looks, by the baseline scan, it looks like a very localized disease with no mediastinal nodes at all involved at all.
So my question to the surgeon, Dr. Robin, would be, so would you, insist on a pre-surgical testing to confirm that this is malignant disease? or in any case there is a lit up lesion, you know, on the PET CT scan, you like to go in for surgery and maybe do the frozen section and proceed. Dr. Robin from Kolkata, is he there? Or Dr. Priya?
Am I audible, sir?
Yeah, Dr. Priya?
So I would definitely ask for a CT guided biopsy. India being a TB endemic country, it is I wouldn't go in without a biopsy for any of the patients unless it's maybe a thymus. So yes, definitely a CT guided biopsy is a must for this patient, sir.
Okay, so I think there seems to be consensus because Dr. Chakor and Dr. Priya feel that we should have a tissue. Dr. Kaushal, you agree to this?
Yes, sir. I agree. And in the quantity of tissue, I want actually at least 3 to 4 cores should be there for the biopsy if possible. And definitely a CT guided biopsy before ascertain the resectability. So to confirm the diagnosis, because in India, this stage 1 and stage 2 incidence is very less. So first we have to confirm, then only we will proceed for the surgery, I think.
Okay, so I think everybody agrees to this, that we should have a pre-op diagnosis, a confirmed diagnosis of a malignant disease before we, go in for a definitive therapy. Next slide, please. No, I think you went backwards. Next slide. So you got the biopsy, which is an adenocarcinoma, and no molecular testing was done on the CT guided sample. Next slide. So, Dr. Priya, please.
Yes, sir.
What would you like to do further to, before you go in for surgery for this early stage non-small cell lung cancer patient who's 67-year-old, fit, non-smoker?
Yeah, okay. So, sir, I would definitely still do a mediastinal staging because unless it's a T1 less than a centimeter, we would prefer to have a confirmed N0. So, yes, I would do a EBUS as well as an MRI brain. We've been actually seeing a lot of patients who are early stage, very small tumors, but they have an oligomet. So, the treatment guidelines and the prognosis of the patient changes completely. So, I would do a EBUS followed by an MRI brain and then proceed for upfront surgery.
All right. So I think Dr. Ashish, you have anything more or different to ask for?
No, sir. I think the negative predictive value of PET is pretty good. So if PET says mediastinum is clear, we can go by that. I mean, the chances of us finding nodes even on a mediastinoscopy or even surgery is less. It's only when PET says it's positive, then we are sure only 60 to 70% of time. So I'm pretty certain that this patient has a node negative cancer. I mean, cancer we have not confirmed, but I think on
cancer we confirmed. It is an adenocarcinoma. We confirmed that.
Right, sir. So then now I think the ball is in the surgeon's court, and patient has to be worked up for fitness for surgery.
Yeah. So the surgeon is insisting on mediastinoscopy. Chakor, you agree for mediastinal staging before the surgery?
Yes, sir. I'll go for that because there is possibility of finding a mediastinal node positive on EBUS, and so it will be better to do a mediastinal staging.
Okay, next slide. I think the same slide. Yeah. So this is what the NCCN 2021 guideline says. That of course we have to look at the lung function tests, pulmonary function tests, because you are removing a part of the lung. So it should be an adequate residual lung function after the surgery. And the pathologic mediastinal lymph node evaluation is sort of recommended here, as you can see. And brain MRI with contrast, say for stage 2 and 3A, and optional for stage 1B. So that is the current guideline. Next slide. Can I have the next slide, please? Okay, so these are the clinical assessment, pre-treatment evaluation. Again, depending upon, if it's an early stage, as we saw before, one can, skip the MRI, I guess, if the PET CT is okay. But you need the mediastinal staging, which is quite critical, for these patients. Next slide, please. Okay, so Dr. Priya, for T1 peripheral lesions, can we skip the mediastinal staging?
Yes, sir. T1, definitely. T1A, at least A and B, yes.
Okay, so you said you wanted to do mediastinoscopy.
Anything more than 1 centimeter. We would prefer so T1 is the only lesion where in peripheral T1 is the only sort of lesions where we can skip mediastinal staging. If we see the PET CT, it was only mentioned early stage. The size was not mentioned. So if I consider anything more than T1, I would definitely go ahead and do a mediastinal staging. Only a peripheral T1 N0 on PET, I would probably skip it.
Right. So I think this is about 3 centimeter tumor, and it is little on the periphery, but then I think this would call for.
Yeah.
So what is the best procedure for mediastinal staging to such patients?
So from our angle, EBUS has been shown to do quite well. The values have improved, the yield has improved for a lot of pulmonologists now with the learning curve. So yes, the first stage is only EBUS. If EBUS gets us enough samples, then we would not need anything else.
So what about the difficult stations for EBUS? Do you have any specific, criteria to decide that this patient should also undergo a mediastinoscopy before the surgery is performed?
No, sometimes we do advise the EBUS with the EUS, but not always a mediastinoscopy.
So by and large, what I understand is that mediastinoscopy is quite, it's not done very frequently these days, right?
It is kept in the back of the list, sir, because EBUS is much less invasive, much less of a risky procedure. Patient tolerates them much better. So mediastinoscopy is definitely done at institutes, but less commonly than EBUS now, sir.
So if you have 100 patients of, stage 2 or maximum 3A, so what percentage would go for mediastinoscopy?
Hardly 15.
Out of 100.
15 to 18%, I think so.
Okay, 15%, still 15%.
Yes.
So any thoughts from the medical oncologist on staging in the for the mediastinum, Dr. Kaushal?
It's the same. We also advise the EBUS guided mediastinal staging in our routine.
Ashish, any thoughts there?
Yes, so the bottom line is that we do not want a futile thoracotomy for a patient. So we have to, we have to do everything possible before we take the patient for a surgery, that this should not be a multistation N2 or an N3 disease, which we missed based on, because we know that the sensitivity of whatever we do, the reach, everything there are limitations. So if you do a surgery for somebody who has multistation N2 or N3, then that patient doesn't do well and he doesn't benefit from the surgery at all. So that's the bottom line. And we use all the expertise available at your center, and especially the PET is a good thing to do upfront because it tells you where to put your needle. The needle will be EBUS guided or mediastinoscopy or CT guided, that we can decide in an MDT, and then take the discussion from there.
So Dr. Priya, if the patient has a 3 centimeter lesion and the PET CT does not show any lymph node, would you still ask an EBUS or you would go for surgery?
So 3 centimeter would say T1C, right, sir?
Yeah.
No, probably 3 centimeter would be a borderline. You're putting me in a fix here.
That is what we want to learn, I mean, so, okay, I mean, let me say 3.5 or 4 centimeters.
Then I would definitely do it.
3 centimeter, I'm sorry to have, put you in spot. I didn't mean that.
No, sir. Means if I'm on the conservative side, I would probably still do it. But if it's a T1B, definitely I'll skip it. T1C is like, I'll see how the patient is overall, the general condition, and individualize it and put it forth in my MDT also. Like definitely Dr. Ashish said that also helps a lot in all decision making. So if I have such a patient, I'll probably also put it in the tumor board and see where the consensus for that particular patient goes.
Great. So these are, important takeaways for all of us, that where we must go for EBUS and where maybe we can discuss it in the tumor board, whether we want to go ahead with the EBUS or skip it. depending upon the size of the tumor and what we are seeing on the PET CT scan. So can we go to the next slide, please? Okay, so I think this patient did not, they couldn't locate a node in the mediastinum and underwent surgery. Next. Yeah, so here I think they did see node positivity, and the size of the tumor is 2.9, 2.5 into 2.0 centimeter without any visceral pleural invasion and no lymphovascular invasion. So, but the node is positive, I think 2 nodes are positive out of several resected. So another question to Dr. Priya. So like you see in, colon cancer or in maybe even stomach cancer, so is the adequacy of surgery judged by the number of nodes removed?
Yeah, routinely we count around 12, but is a criteria is around 12. But we have seen a lot of times post chemotherapy, the yield becomes less if the patient is coming up after a new adjuvant chemotherapy. But 12 to 15 is a guideline for node mediastinal lymph node dissection, sir.
So, Dr. Kaushal, do you routinely see so many nodes removed, in lung cancer patients in your clinic or in your hospital?
No, in my practice, I am not seeing, sir. In my center, I think.
So, how many
very
nodes?
few only with this thing, 12 to 15 node. Otherwise, very few node they are removing.
Dr. Chakor?
I have not seen too much yet at my center.
Yeah. Dr. Chakor?
So not frequently. So few times, yes.
So mostly it is 3, 4, 5?
5, yes. Up to 5, 6.
Dr. Ashish?
Yes, sir. I think it also depends on the location, and most surgeons, if the nodes are enlarged, they go after it and they remove it. And
Right.
systematically doing mediastinal lymph node dissection in pathologically normal appearing nodes, I'm not sure if there is a standard guidelines anywhere, but any abnormal node should be sampled. And I think here for this patient, the station 10 and 11 may be just regional nodes, and these are microscopic deposits which no imaging would have picked up.
Right. So, Dr. Priya, why is it that surgeons are, it's not casting any aspersions on anybody. So, as Kaushal said and as Chakor said, people are only seeing 5, 4 nodes,
Sir, actually, I think what Dr. Ashish said, that a lot of people think that sampling is adequate, but for normally an onco surgeon, the principle is not, it's not yet proved to be sampling. So a systematic lymph node dissection depending on the lobe, yes. So right side we do take 2, 3, 4 and we'll take 8 onwards, and similarly on the left side we'll take 5, 6. But yet if a surgeon has done a systematic lymph node dissection from as per the lobe defined, the yield is guidelines say should be around 12 plus. So in my institute with the team I work with, at an average I see 50 to 16 nodes minimum harvested in each patient, positive or
Great.
negative.
So, I think I'm sure there are a lot of medical and maybe radiation and maybe, I don't know, if surgical oncologists are listening. So, I think it's an important take home that we discuss and go back home with our surgeons. Because in colon and in stomach, we've all passed on this message, and there's a lot of discussion on the number of nodes which should be removed in a patient with non-small cell lung cancer when the patient is being operated. So I think it's an important take home to my mind, because no treatment can replace the surgery or surgical removal. So even if you're doing chemo or target or radiation, if at all, surgery is so very critical. Adequate surgery is so very critical in a patient with early stage lung cancer. So can we go to the next slide, please? Okay, so the question is regarding the reflex molecular testing. So is it done as a reflex when the sample goes there, or you need a prescription from the surgeon or from the medical oncologist? So Dr. Priya, what is at your place?
Yes, sir. At my center, we routinely do molecular testing of the resected sample more for academic reasons also. But a form is duly asked from the surgical oncologist, and molecular testing is done at our center.
Okay, Dr. Kalra, please.
Yes, sir. They are not sending. We have to prescribe this thing, molecular testing. They are not doing routinely.
So the medical oncologist, the patient is referred to medical oncologist, and then Dr. Chakor.
Yes, sir. So here also we do, the pathologists don't do it reflexly, and like we request and then it is done.
And Dr. Ashish, please.
Yes, sir. I mean, we have to request the pathologist because there are payments involved, and nowadays there are too many tests, so they need to know what to do.
Okay, so I think the practice is to go through the medical oncologist. Next slide. I think we are short of time, so I think we don't have a pathologist. I think we are. Next slide, please. We can rush through a few more slides. So I think this is. So I think we have covered this part, and I think Dr. Kalra, what is the methodology? Is it the NGS or is it the PCR? I mean, you go once. How do you do the testing these days?
So NGS.
NGS.
We'll go for NGS only. Yeah.
Dr. Chakor.
So sir, for adjuvant, for such a setting, I'll prefer PCR because the data is mainly for EGFR. So even PCR is okay. So
okay, yeah, right.
Is good.
Correct.
So actually, everything they have to see is my point. IL cross also we have to see if there is we have to start a durvalumab. We have to rule out this EGFR, IL cross, these mutations also, because we have seen this in durvalumab. If these mutations are there, durvalumab won't benefit. That's why I will go for this.
So durvalumab is only for patients who are undergoing CTRT. Here there is a resected patient where all disease has been removed. So such a patient may not be suitable for durvalumab. But anyway, the question is, this patient is stage 2 adeno-CA and is EGFR mutation positive. So Chakor, is there a role for adjuvant chemo or osimertinib with or without chemo?
So sir, the data is pretty good for osimertinib, and so we can just start with osimertinib in such a patient.
Okay, so no chemo?
We can skip the chemo.
You can skip the chemo. Dr. Kaushal?
Sir, I will give chemo followed by this thing, maintenance osimertinib.
Right. Ashish, Dr. Ashish, please.
Sir, we are running short of time.
This last question. Dr. Ashish, please. This is an important one.
So chemotherapy, is node positive. So node positive patients in my practice, all of them get chemotherapy, at least 4 cycles. And that's.
Followed by osimertinib if the patient can afford?
Yes, sir, definitely ADAURA data has to be discussed. We can't ignore it with such big separation of the curves. And I will be happy to see the OS data also. In a couple of years, we should have that.
So my final question to the 3 medical oncologists, if the tumor is only 2 centimeters and there is no node involvement, so it's even earlier than that. So Ashish, will you give chemo or only osimertinib, or what would you do?
So yes, sir, I mean that is a tricky thing. In ADAURA trial, I think the inclusion criteria was 1B and above.
1B,
so
yeah.
yes, sir. So that is, but again, the benefit is more if the risk is more. So for smaller size patients, but this is lung cancer, it's not breast cancer. Even with a small node negative, the relapse rates are pretty high, 40-50% sometimes.
Osimertinib, yes or no? Chemo, yes or no?
Chemotherapy, yes, if the patient is fit.
2 centimeter tumor, node negative. And in the ADAURA study, there were 60% patients who did not get chemo.
Yeah. So yeah, I mean the Anita and those meta-analysis would tell me that not to give for such small tumors. Yes, sir.
Chemo, so only osimertinib,
yes,
right?
Sir.
Yeah, Dr. Kaushal, 2 centimeter node negative.
Yes, sir. Actually, after 2A only we'll give adjuvant chemotherapy. In 1B also is doubtful, so I will not give.
So osimertinib you will give?
Osimertinib, sir, the tricky thing, I think we should give. Benefit out we should give.
Okay, I see. Chakor, what do you think?
I agree with both of them, sir. Just osimertinib alone.
So. Okay, so I think small tumor not fit for chemo, less than 4 centimeter, osimertinib alone would be a choice. So I think we tried to cover a few things here in this panel discussion. So I'm thankful to the organizers. Thanks to Priya, Kaushal, Ashish, and Dr. Chakor for the interactive session. Thank you very much.
Thank you so much, sir. It was good fun.
Thank you, sir.
Thank you, sir. मैं लीव करता हूँ.
So we will be moving directly to our next session, and we are running short of time. So I would like to invite Dr. Pankaj Shah. Sir is a Vice President of Gujarat Cancer Society. He is a Senior Medical Oncologist from Ahmedabad. Over to you, sir. So we will move to our first presentation. I would like to call Dr. Rushabh Kothari. He is a founder director of Oncovin Cancer Center and a consultant medical oncologist from Ahmedabad.
Am I audible?
Yes, Rushabh, you are audible.
Okay. Can you please share my slides? Thank you. So, thank you. I will be presenting evidence of phase 3 randomized control trial where ecotinib, which is a first generation TKI available in China, is compared with chemotherapy as adjuvant treatment for stage 2, stage 3A EGFR mutant NSCLC. Next slide, please. Background. So, operable lung cancer, as we know, has high risk of recurrence. Even for stage 2 and 3A, the risk of recurrence is significant. Adjuvant chemotherapy has a definite role in stage 2 and 3A, which has been shown even in meta-analysis. Adjuvant TKI in EGFR positive patient has never been compared to adjuvant chemotherapy in randomized fashion, especially ecotinib, which is first generation TKI in China. We have some data for erlotinib and geftinib, and now we have data for osimertinib, but that is chemo followed by TKI versus placebo in ADORA. So previous studies with geftinib have shown TKI has better disease-free survival and lesser adverse events compared to chemotherapy. But from what the data is there for ecotinib, it seems that it is better tolerated than geftinib. So here they have tried to compare ecotinib versus adjuvant chemotherapy. So adjuvant ecotinib for 2 years versus adjuvant chemotherapy around 4 cycles. Next slide, please. So patient included were 18 to 70 years. Patient 8 weeks post R0 resection of tumor, EGFR exon 19 or exon 21. So the standard mutations were taken. Stage 2, stage 3A patient with good performance status of 0 or 1. The randomization was 1:1 and it was stratified according to stage 2 versus 3A, EGFR mutation type exon 19 versus exon 21, type of surgery, pneumonectomy versus lobectomy. And randomization was to 2 years of adjuvant ecotinib versus 4 cycles of vinorelbine cisplatin or pemetrexed cisplatin. Next slide, please. So they followed up the patient with CCT thorax and USG abdomen pelvis every 12 weeks in first 2 years and every 24 weeks in year 3 to 5. Brain imaging and bone scan were done every 48 weeks, and if there was clinical indication, this imaging was repeated in between. Primary endpoint of the trial was disease-free survival, and secondary endpoints were 3-year disease-free survival, overall survival, safety, and quality of life. Next slide, please. So as we can see that disease-free survival is significantly better with ecotinib. Median is 47 months versus 22.1 month in chemotherapy arm with hazard ratio of 0.36, not nearing unity. The confidence interval is 0.24 to 0.55 and with a very significant p-value. Next slide, please. And this is seen across all subgroups, irrespective of clinical stage, irrespective of mutation type, irrespective of type of surgery, lymph nodal status, smoking history, age, sex, or performance status. So overall, all the subgroups are benefiting significantly with adjuvant ecotinib, but this is for disease-free survival. Next slide, please. The secondary endpoint 3-year disease-free survival was 63.9% versus 32.5% with chemotherapy. Overall survival data is immature. There was only 9 events in both the arms, so it is too early to say on overall survival. Quality of life was similar at 36 weeks in both the arms. Next slide, please. So the toxicity pattern, as we expect that there were more skin, nail changes and diarrhea with TKI, and chemotherapy there were more cytopenias. Obviously chemotherapy toxicity was for 3 to 4 months, while for erlotinib it was for around 2 years. So the duration of toxicity is also important when we are giving adjuvant treatment. Next slide, please. So my take, I think for this adjuvant studies, overall survival is a better endpoint than disease-free survival. ADAURA design is better strategy as adjuvant chemotherapy is known to have overall survival advantage. So why not to give chemotherapy followed by adjuvant TKI? Osimertinib has more CNS activity, and most patients in this study who were on chemotherapy arm, most of them, around 45 to 50% of them have failed in brain. So osimertinib being more CNS active drug and most tolerable TKI amongst the one which we have used in first generation, second generation, third generation, I think that would be a better idea to give as an adjuvant treatment compared to other TKIs. And this all is, I am assuming that it will have overall survival advantage. And one more debatable thing is duration of adjuvant TKI. So there are studies with 1 year, 2 years and 3 years. We don't know how long to give. So whether to give TKI as a sequential thing versus adjuvant, whether adjuvant or first line metastatic setting is something which is still debatable. Until we have overall survival data, we won't be able to have the clear cut answer on it. Thank you.
So I invite Dr. Ram Abhinav. He's a consultant medical oncologist from Coimbatore for his next talk.
Yeah, I thank you for the opportunity. My abstract for today is adding bevacizumab to erlotinib as a first-line treatment in advanced EGFR mutant NSCLC. This is a follow-up results of the randomized phase 2 JO25567 study. To give a brief introduction, TKIs in EGFR mutated lung cancer have shown improvement in progression-free survival over chemotherapy, but ultimately they develop resistance and relapses. This has been the major problem. So bevacizumab has shown improvement in drug delivery through multiple hypothetical mechanisms, which includes normalizing the tumor vascular permeability. So it was an idea to compare JO25567 compared erlotinib with erlotinib and bevacizumab. And the primary analysis showed that there was a significant PFS benefit with the addition of bevacizumab to erlotinib, but the OS data was not mature. So this study is shows updated PFS and final OS data, which is being presented. So it's a phase 2 study which examined the addition of bevacizumab to erlotinib in the first line, and these were non-squamous NSCLC patients, and these patients were randomized to erlotinib 50 mg versus erlotinib plus bevacizumab 15 mg per kg given every 3 weekly till progression. And point to be noted, it's a phase 2 study and the primary endpoint was progression-free survival, and OS was calculated as a post-hoc analysis. Coming to the results, 154 patients, these are randomized to erlotinib bev 75 and erlotinib number 77. The median PFS was better on combination of bevacizumab and erlotinib. It was 16.4 months versus 9.8 months in erlotinib alone. But the final OS was not different between the two arms. So the addition of bevacizumab did not have have an overall survival, but it did have an improvement in progression-free survival. So this is the first graph showing improvement in progression-free survival. So initially, the addition of bevacizumab showed an improvement in progression-free survival. It was 16 months versus 9 months, but this was the primary endpoint. But in the overall survival, it was all equal. On the subgroup analysis, the exon 19 and exon 21, that is exon 19 deletion, it was similar. There was no significant differences between the two arms, and so was L858R. The bevacizumab did not have a difference in overall survival. So coming to the safety, bevacizumab is a drug which we have a long experience. That was events were similar between the two arms, except that hypertension was higher in the bevacizumab ERLO arm. So to conclude, so addition of bevacizumab to erlotinib significantly improved PFS, but not overall survival. But the study was powered for PFS, and OS was a post-hoc analysis. The authors comment that there were a lot of misses in the follow-up, and the addition of second-line therapy, third-line therapy did make an impact. But having said that, there is a phase 3 trial, NEJ026, that also did not show any improvement in overall survival, the addition of bevacizumab to erlotinib. So my take is that I wouldn't consider routinely adding bevacizumab for all EGFR mutant patients in the first line because of PFS advantage, but rather discuss other options like osimertinib, dacometinib, or even TKA plus chemotherapy. Thank you.
I will invite Dr. Arun Chandrasekharan. He is a senior medical oncologist from Kozhikode, Kerala. Over to you, Dr. Arun.
Thank you, Sunil, and thank you for the opportunity. Yeah, it's Kozhikode, difficult to pronounce. That's why I write it specifically that way. So anyway, what we're going to discuss, this abstract was presented in ESMO 2021, and it's from Japan, and it looked at a comparison of osimertinib plus bevacizumab versus osimertinib monotherapy in patients with non-squamous lung cancer with EGFR mutations. So this was a phase 2 study, and we know that osimertinib now has become the gold standard according to the FLORA trial in first-line treatment of EGFR mutated lung cancer. And there has been studies telling that the addition of a VEGF inhibitor to TKI is better than using TKI alone, but this is mostly in the first generation TKIs. We do not know the answer with third generation TKIs. So this phase 2 trial was set up to do this. So this was the study design, and they included patients with non-squamous, non-small cell lung cancer with EGFR activating mutations 19 and 21. And they included stages from stage 3B to 4, and the rest is routine. They excluded patients who had symptomatic brain metastasis. So there are a total of 122 patients, and they were randomized 1:1 into osimertinib plus Bev versus osimertinib alone. And Bev was given at 15 milligram per kg, and this was continued till progression. The primary endpoint, as this was a phase 2 trial, was progression-free survival by the blinded independent review. And patients were stratified based on their sex, on their stage, and what kind of mutation they had. So the statistical consideration in this was that we know osimertinib has a PFS of around 18 months. Addition of bevacizumab would increase this to 27 months. Now that was the statistical consideration. So the trial was prepared in this way. So this is a consort diagram where the patients were randomized, 61 in one arm, 61, and also 61 in the other arm as well. And the baseline characteristics were more or less well balanced. A significant proportion, I'd say around 50% in the osimertinib monotherapy arm were ever smokers, patients who had a history of smoking. And it was only 37% in the osimertinib plus Bev arm. There was a slight mismatch there, but this tells you that a significant number of smokers were there. Other than that, the EGFR mutation was fairly well balanced, 60% versus 40% like in clinical practice. So this was the primary endpoint, and the primary endpoint, which was PFS in the whole population, was not significant. So this was a negative trial. The addition of bevacizumab to osimertinib did not improve the progression-free survival compared to osimertinib alone. The median PFS was 20 months in the monotherapy arm versus 22 months in the bev arm. The difference not statistically significant. The secondary endpoint was the PFS assessed by investigators, and this again also was not statistically significant, 17 months versus 24 months. Moving on to various subgroup analysis, again you can see it's scattered in both sides across the chart. So there's neither one group doing much better than the other, except for if you look really carefully, you can see that exon 19 may be doing slightly better, and also patients who were smokers, ever smokers, they had a slightly better advantage. But this is again this subgroup analysis, small numbers. So because this was a sponsored trial, we had to look at further details, look at specific subgroups who would benefit, and one of the subgroups were ever smokers, where OC plus Bev had a slightly better advantage compared to osimertinib alone. In never smokers, the difference was not significant. And if you look at the PFS by EGFR mutation status, exon 19 mutations did slightly better hazard ratios, where exon 21 had not much of differences. Again, these are subgroup analysis with numbers to less than 40 patients. So this is just, as they say, hypothesis generating. The response rates are more or less balanced in both arms, 86 versus 82%. 1% had complete response when we used BEV. And the final overall survival, this was immediate but secondary endpoint. But again, as you can see, the curves are all over each other. There is no difference in overall survival as well, which was not reached in both arms. Safety of the combination, if you're using osimertinib plus BEV, you had more discontinuation, almost double the discontinuation of using osimertinib alone. Severe side effects in 11% versus 5%. And death was not seen or reported in this trial. If you look at the most common adverse events, we know that diarrhea, paronychia, and mucositis are going to be there in both arms because of osimertinib. Pneumonitis is something surprising. What was found, 18% had pneumonitis in the monotherapy arm, but when you used bevacizumab along with osimertinib, the number was only 3.3%. So does bevacizumab actually reduce the chances of pneumonitis? That's a question which needs answering. The BEV-induced toxicity of hypertension, epistaxis, and proteinuria was significantly more in the experimental arm as well. So the final summary is that this trial failed to show a benefit of using OC plus BEV when you compare it with osimertinib alone in upfront EGFR mutated patients. The only subgroups were ever smokers or patients who had a deletion exon 19, but again, this is a subgroup analysis of phase 2 trial. In this combination, also might reduce the risk of, as I discussed, the combination of bevacizumab might reduce the risk of pneumonitis. My final take is, would I use this combination? No. The reason I believe is because osimertinib is very good by itself. BEV doesn't add much to the clinical picture. The second point is, which is the extreme rare patient that you could use this, probably somebody who's got interstitial lung disease and you're scared of using osimertinib because of the TK-induced pneumonitis. You can add BEV for that extra advantage, but again, this is just experimental. It has to be confirmed. Thank you.
So for the next talk, I will invite Dr. Nandini Menon. She is a senior medical oncologist at TMH Mumbai. Over to you.
Good evening, everyone. The abstract that I have been given to discuss today is the randomized trial of afatinib with cetuximab versus afatinib alone for the first-line treatment of EGFR mutant non-small cell lung cancer. These are the final results from the SWOG S1403 study. So as we know, in most of the first generation EGFR TKIs, resistance develops between 9 to 12 months after treatment, and there are multiple strategies designed to overcome this resistance because of the identification of all the resistant pathways. We know that 50 to 60% of the resistance is because of T790M, and osimertinib is effective in this scenario. So this study is based on preclinical evidence of afatinib and cetuximab, which delayed resistance in mouse models, as well as evidence from a phase 1b study, which was conducted in patients with EGFR mutant NSCLC who had progressed on first-line EGFR TKIs. So the study design, this was initially designed as a phase 2 going to phase 3 trial, which was supposed to enroll 605 patients, and after a futility analysis progressed to phase 3 if the trial was not futile. However, due to poor accrual, they stopped it in the phase 2 phase and readjusted the sample size to the 178 patients and the phase 2 endpoint as PFS. So here, adult patients with treatment-naive non-small cell lung cancers were included. They only included EGFR exon 19 deletions or L858R, and rare mutations were excluded. Patients with a performance status of 0 to 2 were included, and asymptomatic brain mets which did not require steroids were allowed to be enrolled in the study. So the patients were randomized 1:1 to either afatinib alone or cetuximab with afatinib, and cetuximab was given at the dose of 500 milligram per meter square every 2 weeks. So this is the CONSORT diagram. Ultimately, 78 patients received the cetuximab plus afatinib combination, and 85 received afatinib alone, and these were included in the safety analysis. And 83 patients who were initially randomized to the set combination arm and 85 in this afatinib alone arm were included for the primary analysis. So important things to note in the baseline characteristics: 2/3 of the patient had EGFR exon 19 deletions. Almost 95% were adenocarcinomas, and around 1/4 of the patient had brain metastasis. So the primary endpoint of this study was PFS. And this is the curve which is showing the progression-free survival in the arms, that is afatinib versus afatinib with cetuximab. As you can see, there has been no benefit of the addition of cetuximab in these patients, and the hazard ratio was 1.1, and this was not significant. This forest plot shows the effect or the impact of addition of cetuximab in various subgroups, and as you can see here, there is no benefit of adding the cetuximab to afatinib monotherapy. So secondary endpoints for response rate, overall survival, toxicity. So we'll go through them one by one. So again, this Kaplan-Meier curve shows the overall survival, which is nearly overlapping on both the arms, and there was no benefit, significant benefit noted with the addition of cetuximab to afatinib. The hazard ratio was 0.82 and a P of 0.44. And if you look at the subgroup analysis, just like the progression-free survival, the overall survival did not seem to benefit. The addition of cetuximab did not benefit in various subgroups, including EGFR mutation, PS, or other factors such as age and gender. Another important thing to note is that the addition of cetuximab did not improve the response rates in the study. In afatinib alone arm, it was 74%, whereas it was 67% in the combination arm. The time to response and the median duration of response was similar in both the arms. So this is additional data where it shows the PFS and OS based on the EGFR mutation, that is exon 19. There has been no difference in the arms in exon 19 deletion patients, as well as exon 21 L858R patients, where the addition of cetuximab to afatinib didn't seem to improve outcomes in this group as well. An important part of the study is the adverse events, and if you look at the adverse events, the incidence of grade 3 or higher adverse events was 72% in the combination arm versus 40% in the afatinib alone arm. So this you can see is grade 3, 4, and 5 adverse events in this afatinib plus cetuximab arm. And if you look at this, this is the grade 3 and 4 events in the afatinib alone arm, and this was significantly increased. Also, skin toxicities was significantly higher. You can see the dry skin, paronychia, acneiform rash, maculopapular rash. The incidence of grade 3 toxicities in these were significantly higher with the addition of cetuximab, which we know would have made a significant impact on the patient, also on quality of life. And you can see many places there have been no grade 3 incidence of paranoia with afatinib, but you can see here 5% of patients had grade 3 paranoia with the combination. Another thing to note were the treatment-related deaths and the dose reductions and discontinuations. There was one death related to treatment in the combination arm. There was a significant increase in dose reductions in the combination arm. You can see nearly 60% had a dose reduction. Either afatinib was decreased to 30 mg or to 20 mg, whereas in the single afatinib arm, that is afatinib alone arm, it was much lower. 30% discontinued cetuximab in the afatinib plus cetuximab arm. That is, out of 75 patients, 25 patients did not take cetuximab, and the median number of cycles taken were around 9. So to conclude, this study, where the combination of afatinib and cetuximab in newly diagnosed patients with EGFR mutated lung cancer showed no improvement in outcomes, increased toxicity, frequent dose reductions, and frequent treatment discontinuation. So my take on the study, there have been prior studies with the use of anti-EGFR drugs with the EGFR TKI, but this study has failed. The probable reasons would be the setting. This study was a in the first line setting in treatment naive patients. Prior studies used it in patients who had treatment failure and already probably had active resistance pathways, and the addition of the second drug, that is an anti-EGFR drug, would have worked better. Whether the strategy is right in a newly diagnosed patient, whether dual inhibition of EGFR without amplification, overexpression, or known resistant mutations will really improve outcomes, or whether it is better to target two different pathways to get a better benefit. And also the toxicities, the dose reductions, and the treatment discontinuations would have probably led to a loss of benefit, if at all there was any, because of dilution and patient dropouts from the study. So with this, I end my talk. Thank you.
For the next talk, I am inviting Dr. Manisha Singh. She is a senior medical oncologist at Patna. Over to you, Dr. Manisha.
A very good evening to all of you. At the outset, let me thank the organizers for giving me the opportunity to present this paper. And this paper and this abstract is a randomized phase 3 trial of aumolertinib versus gefitinib as a first-line treatment of patients with locally advanced metastatic non-small cell lung cancer who are exhibiting 19-del mutation or LAT58R mutation. So,
Ma'am, sorry to interrupt you. Can you put the slideshow on? We can't see your slides in the full screen.
Ma'am, you can.
is it visible?
Yeah, thank you.
Thank you so much. So, this is a randomized phase 3 trial of aumolertinib versus gefitinib as a first-line treatment with locally advanced non-small cell lung cancer who are exhibiting EGFR 19-del mutation or LAT58R mutation. So, this is a very interesting paper because, you know, when we think of another molecule in an EGFR mutated patient, what information that will help us improve our treatment. So we are dealing with exon 19 del, we are dealing with exon 20 insertion and exon 21 substitution, that is a bad disease, what we call it a LAT58R, and also some uncommon EGFR mutations. So for exon 19, we know that historically this subgroup has achieved a better outcome than LAT58R. And again, we have understanding that second and third generation TKIs have shown a substantially better progression-free survival as compared to the first line. Now talking about exon 20, this is basically refractory to TKIs and we are still struggling to have a newer molecule which can act upon that. Talking about LAT58R, we know it is a bad disease and the maximum use of drug that we have has given a maximum PFS of not more than 14.4 months. And talking about uncommon mutations, though the number documented is perhaps much less than we talk about, and perhaps we can have a larger number of patients who have uncommon mutations, and only the drug afatinib, which has shown some substantial response on treatment. So with this background, I start with my presentation. We're talking about aumolertinib, which is a new novel irreversible EGFR TKI, and that has shown sensitizing action both against the sensitizing and the resistant mutations of EGFR. So aumolertinib has been approved in China for treatment of patients with EGFR mutation with T790 mutation upon progression of disease on the first line TKI. So this was a randomized trial with 429 patients with the patient's previous untreated metastatic or locally advanced non-small lung cancer, and the trial was designed from November 2018 till September 2019. So the patients were randomized 1:1 with aumolertinib 110 mg OD versus gefitinib 250 mg OD. The primary endpoint was to look for the progression-free survival. The secondary endpoint was to look for the overall survival, ORR, and the duration of response. The trial was powered to 90% with an HR for the PFS with a hazard ratio of 0.67. So when we see the trial design, it said that the patient had an advantage in the PFS 19.3 with aumolertinib versus just 9.9 for gefitinib with a hazard ratio of 0.46 and a significant p-value of 0.0001. Duration of response was also significantly prolonged. It was 18.3 versus 8.1 months. Median overall survival did not reach, and the treatment duration was 463 days with aumolertinib versus 254 days with gefitinib. And the most important, what I found in this trial was the side effect. The serious adverse events were just 4.2% with aumolertinib as compared to 11% with gefitinib. And see, this was the side effect profile. The PFS 19.3 versus 9.9. The median duration of response 18.1 versus 8.3. Selected AEs, if you talk about, there was an increase in alanine transferase 120 versus only 63 for aumolertinib arm. Again, SGOT 116 with gefitinib versus 64. The rashes was still less, 50% as just compared to 89% with gefitinib. Diarrhea was again less, 35 as compared to 77, though there was increase in creatinine phosphokinase. That was 76 for aumolertinib versus 20 with gefitinib. So the trial concluded that aumolertinib significantly improved the PFS and duration of response compared to gefitinib as a first-line therapy in patients with advanced non-small lung cancer with EGFR mutation. Aumolertinib demonstrated a favorable safety profile, especially regarding toxicities mediated by wild type, and these results establish it as a promising agent. But my take is that if you see the EGFR landscape that we have been talking so many frequently during our conferences and webinars, when we sequence these first line, second line, third line, you see gefitinib is always inferior to the second and the third line. We already have shown the superiority of third line as compared to the first line. So the drawback, and what I found that the comparison of this newer molecule is with the gefitinib, which itself is an inferior partner. So head-to-head trials have shown that second and the third generation TKI is a probably preferable agent to first generation for the first line treatment. And again, an important factor that I want to consider here is choosing the most appropriate TKI that also include the type of EGFR mutation that we are having, and that should also include the uncommon mutation, which is, we are more prevalent than the previously thought of. We have just a couple of examples where we are doing an NGS and we are diagnosing this uncommon mutation, but perhaps the number must be higher than what we think of, and that can exist with the already existing mutation, which we can call it a compound mutation already existing with some uncommon mutation, where we don't have the result of this newer molecule. Though the toxicity profile, if you see, aumolertinib has an attractive toxicity profile as compared to the first line gefitinib. So we still need to explore this newer molecule. It seems attractive as concerned to the toxicity profile, but since the comparison with gefitinib is a weaker partner, and I think the comparison should have been with the second or the third generation TKI, where we could have come to a definite conclusion. So this is my take on this newer molecule. Thank you so much for the patient hearing.
Thank you, Dr. Manisha. So we will move to next talk. I invite Dr. Pinaki Mehto. He is a consultant medical oncologist from SCG Cancer Center, Vadodara. Over to you, Dr. Pinaki. Dr. Pinaki has not yet joined, so we will move to our next talk by Dr. Shruti Kate. I invite ma'am. She is a senior medical oncologist at Nashik. Over to you.
Am I audible? I'm so sorry, this was very sudden, so please excuse me for this. Can you put up my slides, please? Am I audible?
Yes, you are audible.
Yes, please put up my slides. So at the outset, I would want to thank the organizers for giving me this opportunity. And should I share the screen from my end?
Yeah, Shruti, go ahead. Share the screen from your end.
Sorry, sir. I think I'll not be able to do that. I have to log in from two devices.
Yeah, please share Dr. Shruti's slide from our end then. Shruti, just 1 minute. It will be shared from our end.
No problem, sir. So the abstract that I am presenting is a Chinese study which was published early in this year. It's a cost-effective analysis for the first-line treatment of advanced EGFR positive.
Shruti, slides are shared. Can you see it from your end?
Yes, sir. Yes, sir.
Okay,
Thank you.
good.
So, cost-effective analysis for first-line treatment of advanced non-small cell lung cancer. Next slide, please. It's an interesting study and one of a kind, I must say. So we know that there is a prolonged survival of patients with EGFR mutation positive NSCLC with EGFR therapies, both as monotherapy as well as combined therapies. But there is definite implications of cost in this, and in a real world situation that is very, very important to find out which is the most cost effective treatment. So this was a cost effectiveness analysis which was conducted to explore an optimal first line treatment in these patients. Next slide, please. So survival data was extracted from 6 clinical trials. We would see which one these were. So these were all which had OS data. Cost related data were obtained from the hospitals and published literature. The effective parameter quality adjusted life year was the reflection of both the survival as well as utility. Then incremental cost effectiveness ratio, ICER, average cost effectiveness ratio, and net benefit were calculated, as well as the willingness to pay, WTP threshold was set from the perspective of the Chinese healthcare system. Sensitivity analysis was performed to explore the stability of results. Intergroup comparisons among multiple trials were done by the Markov model method. Next slide, please. So these were the 6 studies that were included. The Archer 1050 study, which compared dacomitinib with gefitinib. The Flora, which compared osimertinib with the standard first-line TKI. NEJ026 study, where erlobev was compared with erlotinib. NEJ009, PEM carbo Jef versus Jef, and the NCT 02148380 study, again 3 arms, PEM carbo Jef versus PEM carbo versus Jef alone. These were the studies that were included. Next slide, please. So these treatment groups were compared with the control group in each trial, and these were the ICERs, the incremental cost effective ratios, these which were calculated, and the denominator was the quality. Next slide, please. So the average cost effective ratio and the net benefit showed that the combination of EGFR TKI with chemotherapy and osimertinib was of more economic benefit following first generation EGFR TKIs, and sensitivity analysis showed that the impact of utilities and monotherapy could be cost effective with a 50% cost reduction. They were accurate to the sense that they said that for dacomitinib a cost reduction of around 47% and osimertinib a cost reduction of around 51% would actually change the data here, but as of now these are not cost effective if you look at the overall survival advantage that they give. Next slide, please. So first generation TKI therapy remains the most cost effective treatment for these patients, and these results would serve as both a reference for clinical practice as well as formulation of medical insurance reimbursement. Next slide, please. So there were certain limitations to this analysis. It was an intergroup comparison, it was an indirect comparison, and there were definite differences in the inclusion criteria for Flora, the NEJ study, and there was patients where CNS metastasis was included, while for other studies the CNS metastasis was excluded. Again, clinical characteristics, the EGFR mutation type, the proportion of crossover patients, follow-up time, all of these were variable. Next slide, please. Then there were studies which could not be included because the OS data was not mature. The phase 3 delayed trial, the CTONG 1509 trial. So these were not included. Then studies, they showed a distinction between, like I said, the EGFR mutation subtypes, which definitely influence the survival outcome of the first line treatment. Next slide, please. So to conclude, based on survival data from clinical trials, patients' quality of life and current costs of medical resources, standard first generation EGFR TKI remains the most effective treatment option for advanced EGFR mutant and SCLC patients comprehensively. Thank you.
Thank you, Dr. Shruti. Has Dr. Pinaki joined? We will, I invite Dr. Pinaki to start his talk.
Yeah, am I audible?
Yeah, you are audible.
Is my screen visible?
Yes, it is visible.
Okay. Thank you for inviting me for this lecture. So the study that I have been invited to discuss is sequential treatment of afatinib and osimertinib or other regimes in patients who have advanced non-small cell lung cancer harboring EGFR mutations. Results from a real-world study in South Korea called as RESET. So we know that lung cancer is a leading cause of cancer-related deaths. Even in Korea, it is the same. Afatinib is superior to gefitinib as a second-generation TKI. 50% of patients have a T790M mutation when they take afatinib. An AURA study has shown that there is a high ORR and PFS with osimertinib in those patients who have already been treated with another TKI. They have a T790M mutation. So real-world studies are better in the way that they have the poor prognostics patients like elderly patients who have poor performance status, who have the uncommon EGFR mutations and who have brain mets. GEOTAG was a retrospective observational global study which showed that the median TKI period of afatinib followed by osimertinib was around 27.6 months. And patients who had a DEL19, they did better. Also, 50 Asian patients were included in the study, and the median time on TKI was actually very good, 46.7 months. So this is a similar kind of study that was done, a real-world study in South Korea. So it was a real-world experience of sequential treatment of afatinib and osimertinib across 16 medical centers in South Korea. Inclusion criteria was age more than 19 years, EGFR mutated TKI naive advanced stage 3B, stage 4 NSCLC. Treated first line with afatinib and second line with either osimertinib or other treatments. The exclusion criteria, patients who were not treated afatinib first line or osimertinib second line and who were initially treated with CTRT. This is the patient consort diagram. So initially 737 patients were enrolled. However, almost a huge chunk of patients, almost half the patients, 413 patients were excluded because of multiple reasons. I think the more patients because of the lack of data actually. And 324 patients were then randomized into two groups. Group A, 126 patients who had a T790M mutation and therefore received osimertinib, and 198 patients in Group B who did not have a T790M mutation. They received other therapies. Now, the outcome here, primary outcome was the time on treatment. Again, subdivided into time on treatment 1 from afatinib to tumor progression and time on treatment 2 from second line therapy to tumor progression or death. And the overall treatment taught was T1 plus TOT2. The secondary outcomes were the overall response 1 and the overall response rate 2. That is the patients who had either a complete response or a partial response. And the disease control rate 1 and 2, which is the patients who had a complete response, partial response, or a stable disease. The overall survival as well. Now, if you look at the baseline characteristics, the two groups are well balanced. There were more patients who had a stage 4 disease in the Group A as compared to Group B. And there were more patients who had a DEL19 mutation in the Group A as compared to Group B. More patients in the Group B had new or aggravated brain mets as compared to Group A. Now, if you look at the results, in the primary results, the overall time on treatment was better for the Group A. That is the afatinib followed by osimertinib arm. It was 35 months versus 20 months in the Group B. So hazard ratio is quite significant. If you look at the time on treatment 1, again, the patients who were in Group A did better. I think this is because more exon 19 deletions were there in the Group A as compared to Group B. And if you look at the time on treatment 2, that is post afatinib progression, it was 11.9 months versus 5.1 months. So definitely the Group A did better. It was clinically significant. If you look at the different subgroup analysis of which factors influence the adverse results, it was mainly the poor performance status, advanced tumor stage, tissue type other than adenocarcinoma, presence of liver metastasis, and no adjustment of afatinib. Interestingly, they showed that patients whose dose of afatinib was adjusted had a better response. And if you divide into TOT1 and TOT2, so patients who had a advanced tumor stage and liver mets had a decreased TOT1, and patients who had a presence of liver mets, they had a decreased TOT2 in the Group A. If you look at the secondary outcomes, the overall response rate was 75 versus 65%. The overall response to was 40 versus 20%, so definitely significant. If you look at the disease control rates 1 and 2, it is 97 versus 90% and 94%, 75%. If you look at the overall survival, it was not reached in the Group A versus 38.5 months in the Group A. So definitely as a whole, the Group A patients did better than the Group B patients. So conclusion, this was a real world study. So poor prognostic factor patients were included. The overall time on treatment was significantly better in the Group A as compared to Group B, even when all the characteristics like smoking status or EGFR mutations were considered. And it was numerically superior with respect to the overall survival, the disease control rate, as well as the overall response rate. Poor performance status, advanced tumor stage, tissue type other than adenocarcinoma, liver metastasis, and no adjustment of afatinib. These were the adverse factors related to decreased TOT1. And all patients in the Group A, they had a T790M mutation, whereas they did not have in Group B. So it is possible that the T790M mutation affected the natural history, and it is not the sequential treatment which affected the natural history. So the limitations, it was a retrospective study, so selection bias in this classification is possible. The time of treatment 2 was shorter than time of treatment 1. This is opposite to what was in Geotag, but in practical experience, we always see that after progression, the time of treatment is usually lesser. The survival data was not mature in the group at time of analysis. A lot of patients are excluded, so it is not feasible to obtain more detailed information, such as patients who received other treatments or the frequency of T790M. And it is possible that the T790M mutation itself had a impact on the biology and the overall outcome as compared to the non-T790M, because we know that there is no standardized treatment for the non-T790M patients, and generally these patients might have an inferior survival outcome. Thank you.
Thank you. Now, next we are having again one more panel discussion, which will be moderated by Dr. Navneet Singh. He is a senior medical oncologist at Chandigarh. Good evening, sir.
Yeah, hello. Good evening. So, first questions first. Audible, visible?
Yes, sir. Only one change in our panelist. Dr.
Yeah.
Ashish Bakshi is not there, and in
Okay.
place of him, Dr. Nandini Menon, a medical oncologist from Tata Hospital, is joining.
Okay, perfect.
And rest we have all Dr. Sunil Chopde, senior medical oncologist from Tata Hospital, and Dr. Adesh sir, Dr. Darshana ma'am, Dr. Jayant Gawande sir.
Okay, and everybody's there. So, or do I need to invite them?
Yeah, we are there, sir.
Okay, great. So, quick roll call. Dr. Sunil,
Yes, sir. There.
Dr. Jayant,
Dr. Jayant is there?
no.
No, he's not there.
Okay, Dr. Mridul,
Yes, sir. There.
thank you. Dr. Nandini, I
Yeah.
saw so she's here, right? Dr. Adesh,
Not there. Not there.
yet. I think we are 7 minutes ahead, so people might still join at the scheduled time. And Dr. Darshana. Right, thank you. Okay, so now moving on, obviously thanking Kumar Prabhash and Vijay Patil and the entire team for asking me to moderate this session. So I'll start my screen sharing and okay, let me know if you can view it.
Yes, sir. Visible.
Good, thank you. So we are going to spend the next 30 minutes or 35 minutes if we have bonus time talking about treatment of EGFR mutated non-small cell lung cancer. As you have all listened to the previous abstracts presented, 7 of them were all on EGFR. And these are my esteemed panelists. We have already have them here, except for a couple. I think the lone surgical oncologist in the panel, Dr. Adesh, is still not there. So it's right now all medical oncologists. Great. So we had 7 presentations. 2 of them were trials comparing the addition of a monoclonal antibody, either a EGFR monoclonal antibody or a VEGF monoclonal antibody to an EGFR TKI. So cetuximab being added to afatinib and bevacizumab being added to erlotinib. So these were two trials on this combination. Then you had a real world analysis on the sequential effect of osimertinib following initial treatment with afatinib, and a cost-effective analysis of first-line treatments for EGFR mutated NSCLC. Then you had 2 abstracts presented at the ASCO annual meeting and the ESMO Congress, and the first of them was actually looking at a new molecule developed in China compared to gefitinib, and the other one was again similar to the previous study, combining bevacizumab to osimertinib here. It was ironical to me that in this abstract, the highlighted portion was the only thing which was science, and the rest was all conflicts of interest. That was really something amazing. I don't know if you see that too often or not. And the last one was actually on In the adjuvant setting, the evidence trial comparing icodinib versus chemotherapy, we've already had a session on that, so it would probably do justice to focus on the first line initial treatment of EGFR mutated, unresectable, advanced or metastatic NSCLC, because 6 out of the 7 presentations were on that. So we are really very happy as clinicians when we get an EGFR positive report, whether that's a biopsy specimen or a cytology specimen, whether it's L858R or exon 19 deletion, the two commonest ones. But we now know that there are multiple ways how you could treat them. You could give them a first or second generation TKI, then look at T790M. If positive, give a third generation TKI, or if not, then they go on to the pathway of chemo first line and second line. Or you could give a third generation TKI upfront, look for CS79S at progression, give a first generation TKI, if not, again the same pathway. Or you could combine a first generation TKI with pemetrexed platinum. I think it was a wonderful trial led by Vanita and all of the team at Tata. There, maybe at progression, you could again consider osimertinib or go on to docetaxel. And of course, FLORA2 is awaited, third generation TKI with pemetrexed platinum. And then obviously, once that is done, you have just left with docetaxel. Here, of course, we haven't factored in combining VEGF inhibitors or looking at other resistance mechanisms. And basically, the big question is that if you combine different treatment modalities, is the 2 + 1 just 3, or is it actually more than 3? So it's important to look at the numbers. This is just a representation of the FLORA trial, very impressive PFS and OS, statistically significant. Or if you were to do sequential treatment, give a first generation later and third generation later, you would still achieve significantly better results, but maybe not to that level. And if you have data from second generation TKI followed by a third generation TKI, and basically it's not just one option. You have multiple options, and you have to take several factors into consideration. And this is just a representation of how, if you do different things, you would get impressive survival exceeding 2 years, even possibly reaching 3 years, and doing much better than the comparator arm. So now let's get into the panel discussion. So does any of the panelists can comment what you see here?
So there is a lung lesion that is there in the left
upper lobe.
Left upper lobe, right? And
is it visible?
Left upper lobe one is visible, and there is some fibrosis, something that is visible on the right side, kind of fibrotic thing, and right lower lobe some basal changes are there with some nodules. I think that's it.
Good. Okay. Thanks. So basically, this was this is a lung cancer, right? It's a spiculated nodule more than 3 centimeters. But when we treat, we have to look at several other factors. This patient, incidentally, not just had lung cancer, he had severe emphysema, where you can see this, and he had pulmonary fibrosis. So 3 smoking-related diseases in one. But sometimes we have to look at the bigger picture. For example, in this patient's X-ray, you can see a pathological fracture. So we have to take into consideration several things. Let's get down to our discussion with the esteemed panelists. So we have the first case, a 46-year-old male with an exon 19 deletion, no comorbidities, ECOG PS1, no brain mets, significant symptom burden. He's willing to have chemotherapy, has problems with affording expensive treatment. And so I've just listed the several treatment options: first generation TKI, second generation, third generation, chemo plus TKI, erlotinib with the VEGF inhibitors, or any other which things you might have based on the trial data. So let's start one by one. So I'll call Dr. Sunil.
Excuse me, sir. Dr. Jayant also joined now.
Dr. Jayant has also joined. Fine. Okay. Thank you. So Dr. Sunil, your comments, please.
Yeah, so looking at this patient, he is a young patient, 46-year male with no comorbidities. And if there is a financial constraint and is not affordable for osimertinib, I would like to go ahead with chemo plus gefitinib combination, TKI plus chemotherapy combination.
Perfect.
Yeah.
And I understand, makes sense, right? Dr. Mridul?
Yeah, same. The chemotherapy with the Jeffnib combination will be my preferred choice in this setting.
Okay. So, Dr. Nandini, you
So if the patient can't afford a third generation TKI, then Jeftinib with chemotherapy, or if there's a trial which is available, any new drug that is being evaluated for EGFR.
Okay, great. Dr. Darshana? I can't hear you, sorry.
Hello.
Yes.
So my preference would be a chemotherapy-based backbone with a TKI, since he has a high tumor burden with a pathological fracture, or the third generation TKI.
Right, so we seem to be having consensus on the Jeffertnib PEM carbo this thing, and Dr. Jayant has joined. So, do you agree or you have different views?
I agree, but now with generic afatinib available, maybe a second generation afatinib can also be an option.
Okay, so basically, all of you have just opted for Jeffertnib plus chemo, and Dr. Jayant said he might use afatinib. Now, just let's change certain variables in this. So the PS is 0, symptom burden is milder, and can afford practically anything. Would anybody like to change the options?
Afatinib.
Afatinib, okay. And can you just also, if you are changing, please tell why you would choose that option.
So low symptom burden, exon 9.
Okay. And you want to reserve OC after that? I can't hear anybody. Is somebody speaking, or there's a problem?
The mic had an issue.
Okay, great.
Yes, I would like to reserve the osimertinib after using the second generation of afatinib.
Okay.
Yes.
Anybody else has a change in thought, or you are still going with the Jeffertnib plus PEM carbo?
So I would prefer osimertinib, sir.
Osimertinib. Okay, so now we're starting to have divergence of opinions. Afatinib, osimertinib.
Yes, sir.
Okay.
Affordability, if it is affordable, that I would like to offer the better quality of life, better responses on a single tablet, and good tolerance too. So I think osimertinib is the choice from my side.
Correct. But for a young male with no comorbidities, 46, tolerance should not really be an issue, right? And the TMH trial did show that the OS achieved with the Jeffertnib plus PEM carbos was sort of comparable to OC, right?
Yes, I agree, sir. But again, the single pill and the quality of life, it does make a difference when you have to come every 21 days for a cycle, and that thing can also be taken into account, especially when the patient is affordable. Why not go for that?
Okay. Right, and so anybody else has any other change in treatment plan, or it's going to depend upon the patient preferences now in this case, because affordability is not an issue?
No, sir. So I agree with what Dr. Mridul said. Osimertinib, he's a young patient. We can offer better quality of life, probably also better. He has no brain meds, and osimertinib also has good CNS penetration. So if anything is, a patient can afford anything, probably give him the best in the first line itself. So osimertinib, like Dr. Mridul had said before.
Okay, great. Thank you. So let's take another scenario now. So this is a 78-year-old lady, metastatic NSCLC, exon 21 L858R, multiple comorbidities, PS2, no brain mets, a little bit of symptom burden. Not the family and patient herself is not willing for chemotherapy, but they have no issues with the, it has problems with affordability. So I've obviously removed the chemo choice from here because the patient had said no, and the other ones are listed. So let's start one by one again. Dr. Sunil.
So if affordability is not an issue, osimertinib will be my choice of
No, right now affordability is an issue.
So then I would like to go with first generation TKI gefitinib, single agent.
Any preference between gefitinib versus erlotinib?
So I would prefer gefitinib. So it is tolerated better in these elderly patients. With erlotinib, the rash might be troubling, diarrhea might be troubling. So I would prefer gefitinib in this patient.
But hepatotoxicity is more frequent, even though it is the frequency is not great, but it is still higher with gefitinib as compared to erlotinib.
Still, sir, in practice, we see that these elderly patients do tolerate gefitinib well, and they have a disease control.
Right. Dr. Mridul.
So first generation TKI, gefitinib or erlotinib? Gefitinib preferred.
Good. Dr. Nandini?
So I agree with them if the liver functions are not very badly deranged, and otherwise then gefitinib, first generation TKI, gefitinib or erlotinib, preferably gefitinib because of rash and diarrhea issues.
Right. And Dr. Darshana?
So I agree, gefitinib would be my first choice.
And finally, Dr. Jayant.
Yeah, even I'm comfortable with gefitinib.
So again, a consensus on using first generation TKI gefitinib. And again, let's flip things. So instead of comorbidities, you have you have just one, this coronary artery disease, and there are no issues with affordability.
Osimertinib. Still, we choose osimertinib.
Anybody else?
No, I agree, sir. I think also osimertinib is the clear winner over here.
So, what's your experience, or do you have any concerns about the cardiotoxicity of osimertinib?
QT prolongation.
Correct. And this patient has coronary artery disease. She's 78 years old. So, would you do anything differently, or would you be comfortable giving standard dose of osimertinib?
Standard doses with frequent monitoring of ECG, initially maybe weekly, and for the first month, and maybe later bi-weekly, and then we can increase the frequency of monitoring required. But I think the dose I would like to continue the same, 80 milligram.
Okay. And any takers for erlotinib with any of the VEGF inhibitors? Doesn't seem to be a favorite right now. No, it's OC.
So with VEGF also, the risk of the ischemic heart disease, the thrombosis, and it is
Yes.
there. And in fact, I think it will be definitely more because of the prothrombotic properties of the bevacizumab and ramucirumab. So probably, I think it will be difficult choice over here.
Correct. Okay. So I think so. Cost is the probably most important deciding factor. We have seen our panelists. Anytime affordability is not an issue, osimertinib tends to be the preferred drug. But in real life, I think 99% of our patients, at least, I believe TMH setting and my setting were probably just as same, though people will not be able to afford the only legal version of osimertinib. Okay, let's go to the third case now. So 61-year-old male, exon 20 LH61Q, single comorbidity hypertension, PS0, no brain mets, moderate symptom burden, willing for chemo, but has problems with affordability. And again, we start with Dr. Sunil.
Here, I will prefer using second generation afatinib. I would like to use looking at the mutation. And if affordability is there, may think of using osimertinib, but afatinib will be my choice in this patient.
Okay, good. Thank you. Dr. Mridul?
So I would prefer gefitinib with PEM carbo over here.
Okay, any particular reason?
So basically, the combination, it works better. The same reason, no different than the other mutation. I think even this combination is also good, and if the patient has willingness, and although age may be one factor that is against that, he might have more cytopenias, but maybe this one is my preference.
So the TMH team is sitting here, right? So how many patients of uncommon mutations were there in your trial?
Very few patients were included in the study.
Right. It was still largely restricted to the common exon 19 del and L8 5 beta, right?
Yes, yes.
Okay. So the efficacy of the combo has not really been proven for uncommon mutations also, although you might theoretically expect it to work just as good or maybe even perhaps a shade less, right?
Yes, sir.
Okay. All right. So that was Dr. Nandini.
Yes, sir. So, considering the mutation afatinib had in the Lux-Lung 3 and 7 pooled analysis on rare mutations, and this was one of the mutations that were included and did well. So, probably afatinib would be my choice, and if that is not an option, then maybe Jeff with chemo. But based on evidence, and in this case, and so our study did include about some 3 to 4 patients with this mutation, but a small number, as you said.
Correct. So that's not enough to draw any conclusion.
Yes, I agree.
Dr. Darshana.
Sir, afatinib or maybe just the PEM carbo without the gefitinib.
Why exclude the gefitinib? I mean, why not give an EGFR TKI to an EGFR mutated patient?
Because if it would be an afatinib, I would have included. I don't know whether gefitinib would work or not. And considering the age and the comorbidities, do not really want to add to anything.
Well, just one comorbidity, hypertension, well controlled, 61 years, that's not too old.
But
that's the median age of diagnosis.
So I would try, but I mean, that would be my choice to
So at what point of time would you consider an EGFR TKI in this patient if you're going to use chemotherapy first?
Sequential, maybe.
Sequential means when?
After after giving the 6 cycles of PEM carbo.
So you could go on to a pemetrexed maintenance.
Yes, but that was something which I would do, considering the 61 age group symptoms. And the affordability is an issue.
But generic afatinib would be cheaper than giving pemetrexed carboplatin every 3 weeks.
Yes, sir. So that's what I said. My first preference would be afatinib. If not, then a pemetrexed carbo without the gefitinib, with or without. I mean, no special benefit that I would get with an upfront gefitinib.
Okay, all right. Good to have divergent views, Dr. Jayant.
Yeah, so this is an uncommon EGFR mutation, and afatinib has the most data for it, so I would go with afatinib.
Correct. All right. Again, let's flip a few things. Patient has brain mets, PS1 because of brain mets, down from 0, and no issues with affordability.
Mutation is same, sir, right?
Yes. Correct.
Here, affordability is there. I would choose osimertinib. Or we can do whole brain radiation, and then afatinib will be my choice.
Okay. And how strong is the data for uncommon mutations with osimertinib compared to afatinib?
So, in one studies, the results are comparable. Osimertinib has shown the similar benefit like afatinib, but we have more data for afatinib compared to
osimertinib. Small phase 2 study with attempt by the authors to show that it is comparable to afatinib, but there is no denying that the magnitude of data which is available for afatinib is probably strongest for uncommon mutations. So why you have a lot of options now, right? You WBRT. So suppose the patient had one up to 3 lesions which are small. Could you avoid WBRT?
Yes, we can avoid. We can go ahead with SRS and then followed by EGFR TKI.
Okay, and and if you were to explain this to the patient that you have 3 small brain mets, we could give you afatinib plus SRS versus osimertinib. What would you weigh? Which one would weigh better?
So I would like to go ahead with SRS plus afatinib for the patients with uncommon mutations.
Okay.
Even if we are choosing osimertinib, I would like that patient to be treated with SRS and then we'll use osimertinib.
Okay, great. Anybody else has any other opinions? Or
So, if the patient is not very symptomatic and the mets are very tiny and it's not in any critical location which needs to be addressed urgently, I would probably avoid using WBRT if there is access to osimertinib. If the patient is going to live longer with the cognitive side effects of WBRT and other issues. If, of course, the met is symptomatic, it's a large met or there is some critical structures or issues, then radiation will be required. Then it's definitely not a choice. But if I had a choice and the mets were tiny, then I would probably let the patient not get the side effects of radiation.
that's fine. So suppose the decision is not to give WBRT immediately and SRS is not available at a given center. Would you add steroids to osimertinib or not for a mildly symptomatic patient from brain mets?
So if clinically indicated, we would, if the patient had symptoms, and probably taper it quickly.
Okay, good. Thank you. Let me just look at the time. I think we have another 10 minutes or so. So let's move on from this to the adjuvant setting. So I'm not going to discuss the case. I'm just going to get your opinions. So the first question is, would you ask for EGFR mutation testing with or without other markers in potentially resectable NSCLC in the diagnostic biopsy specimen? So maybe the TMH people can answer together and the others can chip in.
Yes,
Yes.
I will ask.
Yes, sir. Of course, we patients don't afford adjuvant osimertinib, but we would like to ask for these mutations.
Okay, indeed. I mean, the plan is to work up for surgery, get surgery, but even at the diagnostic part, you will ask for EGFR testing.
Yes, sir.
And is that the practice elsewhere as well?
So very like we haven't had such a scenario recently since these have been operated. But yes, I would like to include the testing.
Okay, and so the next question is, so that if patients are on NACT, you get the EGFR report, and what are you going to do? Are you going to use this combination of Gefitness plus PEM carbo, or you are going to use another TKI as the solo therapy, or you are just going to ignore the EGFR report, continue with NACT? How does it happen?
So we'll not include EGFR TKI in the neoadjuvant setting. We'll go ahead with chemotherapy only. We'll be concerned about use of TKI in the adjuvant setting.
Okay, so that's fine. So then, if you are not going to act upon the EGFR report, why would you get it tested? If the plan is to get a surgery and you will have the whole surgically resected specimen to do anything you want, NGS or anything, and you are not going to use an EGFR TKI in the neoadjuvant setting, why ask for the report?
So I think I answered for the adjuvant setting only, not for the neoadjuvant. So not for the neoadjuvant, probably for the adjuvant setting we would require.
Adjuvant is fine. I am asking, a patient is being worked up for surgical resection. Obviously, you have a diagnostic specimen which confirms NSCLC adeno. You ask for EGFR or you don't ask for EGFR?
So the rare situation is where there is a path CR and no malignancy in the post-surgical specimen, which is not very common still, but it is usual practice that if we have a EGFR mutation positive, like we can get it done at, in the diagnostic specimen itself.
But the diagnostic specimen is remaining. So suppose you have surgery and it shows us pathological CR, you don't find any tumor. You can always go back, ask for EGFR or any other testing possible in the diagnostic specimen. Why at this point of time, while the patient is being worked up, if you're not going to act upon it?
So there are ongoing trials for neoadjuvant osimertinib. So if we could access like a patient who doesn't want to take neoadjuvant chemotherapy, we could probably like try to get them an access onto ongoing trials. That would be the current reason for getting it done.
I agree completely. I think so. The only reason why somebody who's potentially resectable, you would want any of these markers is to get enrolled in a trial if he or she is eligible. Fine. Now, the surgeon, there was one surgeon, Dr. Adeshi hasn't joined, right? Is he there? No.
No, sir.
I actually wanted to have their opinion. What would they prefer while operating for NACT versus NACTT? Anyway, let's skip that. So the question is now that we just have, I think, 5 minutes or so. So if it is pathological stage 2B, which is T1A to T2B N1 or a T3N0 or a pathological 3A, which is T3N1, completely resected, R0, no lymphovascular invasion, no lymphangitis, no pleural invasion, no STAS. Would you consider an adjuvant EGFR TKI with chemo or after chemotherapy if no NSCT had been given?
So adjuvant chemotherapy followed by TKI.
Okay, so
yeah, like osimertinib, 4 cycles of adjuvant chemotherapy followed by osimertinib maintenance.
ADAURA, right?
Yes.
Okay, so that's the consensus, or anybody is going to think differently?
It's a consensus.
But if patient can't afford osimertinib,
then we would explain to the patient that if they don't want adjuvant chemotherapy, then based on the CTONG data, gefitinib, but with the explanation that overall survival is, there's no significant proven benefit of that. So preferably, if the patient is fit, we would counsel them to go for adjuvant chemo.
right? So patient is fit, but has problems with affordability. So if you complete 4 cycles of adjuvant treatment, would you put the patient on gefitinib or erlotinib generic if patient can't afford osimertinib? I mean, these are the real life situations which we face, right? Every day.
Sir, would like to put him on some first generation TKI maintenance. We'll have a discussion with the patient that we have a data for this drug which is very costly, and if patient is not affordable, we'll also tell them that these are the other options which can be used, though we don't have a strong evidence. So I would like to give him some TKI maintenance.
Okay. And suppose the patient had received NSCT before, I mean, basically it's a YP, 2B or 3A. And so would you use adjuvant EGFR TKI alone?
Yes, if he has received NSCT, then we'll use adjuvant TKI only.
Okay. Ullas has joined and wants to comment. Please, Ullas.
No, I want to ask a question. What would you do?
I am the moderator. I am not supposed to answer.
I am the
you are an expert.
I am the audience. Audience
No,
audience can always
please.
ask the question.
Please tell what you would do or what you are doing currently.
No. You tell me what would you do?
The same. I mean,
So will you give gefitinib?
Again, discuss the patient, can't afford osimertinib. I would not deny an EGFR TKI to a patient who has an EGFR mutation. So complete cisplatin based adjuvant chemo and put him on gefitinib, him or her. What's your practice?
I have a different take. I will not actually give gefitinib. I mean, again, the point is how long do we give? The toxicities of a single generation TKI, let the cost not be there, and the increase in the incidence of brain mets which are there with gefitinib. I mean, we have had patients. We have had 3-4 patients. We actually haven't given. People are doing fine, and have restarted people on the adjuvant TKI on palliative TKIs once they have come back. With the lack of OS advantage, I think it's very difficult to we cannot tilt the data whatever way suits us. If there is an OS advantage and the disease and the drug is costly, we say drug is costly. If there's no OS advantage, drug is cheap, we say drug is cheap. Let's give it. So I think that both the data have to be looked in the same way. So that is why I asked your opinion.
No, but brain mets developing is not because you are giving gefitinib. It is because you are not giving a drug which has good brain penetration.
In CTONG trial, there was a higher incidence of development of brain mets probably at the later part of the time, and that is also one of the reasons what they said why the OS was actually not better in the gefitinib arm. So my take, I would rather, if there is no OS advantage, I would not subject the patient to 2 years of an oral TKI also, which may cost us 5,000 rupees. That's my take.
So you would just put them on observation?
Observation and then wait and see what happens.
And so suppose the patient has a relapse and has a poor PS and you are not able to do much at that time versus if that question arises, had I started or had the patient taken a TKI at that point of time?
I will deal with that question. I will deal with that question at that time also and before starting the treatment also. And I'll again give an example. So maybe, the answer to a maybe is another maybe. Maybe if the patient relapses with one more small nodule to the opposite side and I give SRS or SBRT to that and then continue him on observation without any treatment, then also things are okay. The point is, Navneet, let's forget about EGFR mutant. The point is, you do not have an OS advantage, a documented OS advantage with one particular drug. Will we, just because the drug is cheap and it's easily available, should we be giving it? So my take is no. That's my personal opinion. I know I'm at variance with a lot of other people on this, but that's the way. If you look at science, you look at science.
Well, that's fine. There is no data. So the problem is in real life scenarios, we always don't have data, and so a lot of things are based upon clinician discretion versus discussing with patients what they want. I'm fine with that.
I'll ask you one more this thing. You have a patient of stage 3 NSCLC, CTRT given. It's a EGFR mutant or an ALK this thing. What would you do?
I know.
I will answer that for you. You send it to me. I have a trial going on, LAURA trial. I will put him into the trial.
Oh, that is fine, right? So we're coming up with the ASCO stage 3 guidelines, and this was a very big point of discussion for stage 3 unresectable treated with chemoradiation, and the EGFR status. What would you do? Would you put them on maintenance durvalumab versus TKI? So I think there are divergent opinions across the board here.
More minute only.
They want us to shut up.
1 minute is pending.
Okay, I'm done.
Go ahead, Navneet.
No.
Go ahead.
I am done. So I think.
Okay. Regarding one more point you raised, Navneet, was that whether we will do an EGFR mutation at the beginning of this on the diagnostic biopsy. I think the one reason why we would do is if you want, you very rightly said, if you want to give immunotherapy to the patient. So even if you want to give chemoimmunotherapy, all the AGN studies and all have basically shown that they're excluding people with EGFR and ALK. So that's one of the reasons why we would do a EGFR on the initial blocks. That's just a point.
Okay, so I just like to end by saying that what really matters is being able to test an oncogenic driver and giving the appropriate therapy versus not being able to test or finding something and not being able to give. This is obviously for the metastatic setting, and TMH people, Ullas, nobody needs this. It's just for people who are still in training, that the aim is to test and treat if you find something positive, because that is what makes a difference. And obviously we are now nobody knew it, that even 2021 is going to be all about this. And we are soon going to move to an era where it is going to become more and more complicated. It's not just going to be the type of EGFR mutation, what is there along with it. And so let's hope we have the ability to move through this extremely rapidly changing landscape. Thank you.
Thank you so much, sir.
Thank you, sir.
It was a very interesting session.
Thank you, sir.
Now, with the conclusion of this session, we'll go on to our next session. I will like to invite Dr. Anuradha Chaugule, ma'am, who is a senior consultant in Tata Memorial Hospital, Mumbai, for her next talk on the role of NGS.
Good evening, and thank you organizers for giving me this opportunity to present the role of NGS in MET detection. Really, the MET has been targeted because of the therapy. It is being used as a biomarker, and it is now considered to be an established biomarker when you are doing a whole spectrum of NGS profiling. So, other than EGFR mutations, now we can see there are many of the targetable oncogenic driver mutations are available, like ALK and uncommon mutations. And when there are no targetable oncogenic driver mutations, you would like to go look for the PDL1 and the other immuno-oncology biomarkers. So, as I said, that other than EGFR sensitizing mutations, you get to see the uncommon mutations in very small percentage like ROS, RET, BRAF, and ERBB2. And in the MET exon 14, you can get to see the MET amplification as well as the MET exon 14 skipping, that is the splice mutation, what we call it as. And it is comprised of around 3% of the total mutations. So, ERBB2, as I said, is also another important emerging biomarker which is coming up. But today we will just concentrate on the MET, role of MET in the by detecting through the NGS method. So, what exactly is the MET? It is a proto-oncogene which is located on the chromosome 7, and it encodes a receptor tyrosine kinase which activates the downstream signaling pathways, as you can see over here, like including MAPK, PI3K, AKT pathways, STAT, and NFKB pathway. So in normal conditions in the MET pathway, you get to see the activated binding sites with the hepatocyte growth factor, and with this hepatogrowth factor binding of this ligand, the MET pathway gets activated for the down signaling pathways, down signaling cascades of this MET, PI3K, and other RAS, ERKBB pathway. And this the role of the MET exactly is to regulate the cell survival, proliferation, and motility, and it also contributes to the both physiologic and pathologic processes. So, when there is a pathologic activation, that is when there is a aberrations are present, genomic aberrations on this MET pathway, that there is a tumor cell migration, and through this tumor cell invasion, you get to see the tumor cell proliferation as well as the angiogenesis. And this is how, like, what is the distinct mechanism of this MET dysregulation? You can see it over here. In the normal, when there is a binding of the ligand with the hepato growth factor receptors with the MET, you get to see the receptor activation, receptor internalization, and the receptor degradation. However, when there is a constitutive activity process, or when there is a skipping of exon 14 happens, there you can get to see there is a loss of CBL binding site there, which subsequently go to the decreased ubiquitination. There you get to see the impaired receptor degradation, and thereafter it leads to increased MET signaling. So with this increased MET signaling, there is a lot of MET amplification and seen, and there is an increase in the MET protein, and also in the increase in the mRNA, you get to see the various genomic alterations present. So why it is important to look for the RNA based rather than the DNA based technology for the on the NGS, because of there are various more than 150 different MET exon 14 skippings mutations have been described. As you can see, this is the whole this is the exon 13 and exon 15, and between this is the 141 base pair of exon 14, and this is the amino sequence of nearly 141 bases, but the alterations or the deletions happens between the nucleotide of sequence number from 963 to 1009. So at the 3' end, that is at the acceptor site, that is the splice acceptor site, you get to see the deletions, maximum deletion at around 41% as compared to the 5' that is at the donor side, which is just about 11%. But the maximum mutations at the splice site donor site is being seen is around 48%. So you need to know what exactly you are looking for because of this exon 14 skipping. And when there is a I can just I'll go back to this. I want to explain this slide. Okay, so when there is a exon 14 skipping or when there is a point mutation, you need to know that which platform, technology has to be used, whether it is a RNA based or whether it is a RNA based or whether you should look for the DNA based. So accordingly, actually both the techniques are important. You should look for both RNA based as well as a DNA based, because if there is a whole lot of exon 14 skipping, then there is a fusion formed between the exon 13 and the exon 15, and this the fusion only can be seen at the mRNA level. But however, as I said, there are a lot of mutations also present, point mutations on the DNA. You need to have the DNA based testing as well. So to analyze the genomic variants that which alters or eliminates as a splicing site. So there are, as per the Caucasian population, there is only 3 to 4% of MET exon 14 skipping. But since now that there is a targeted therapy available like capmatinib, it is being used as an important biomarker as per the NCCN guidelines. So the NCCN guidelines also suggest that the MET, there should be the testing of the MET exon 14 at the RNA level as well as at the DNA level, so that none of those point mutations or the fusions are being missed. So there are various methodologies to detect, like you can look for the RT-PCR genomic sequencing, you can do the RNA and exome sequencing, you can do the whole exome sequencing, and on the at the targeted panel you need to have either the amplicon base or the hybrid capture base. But the most preferred one is the hybrid capture, because since there are a lot of the fusion which is there, which can be easily detected by the hybrid capture method. So there are, for the amplification, which is also an important factor to look for the protein expression, because of the poor screening, IHC is not advisable, but the FISH can be used to look for the various amplifications. But however, it has its limitations, like because of the detection limitation, because of the certain genomic alterations only can be looked upon. NGS, yes, a high multiplexing, it has a high multiplexing capability, but however, there is a long turnaround time and it's a expensive. But most of the time, the NGS is the preferred method which should be looked upon. So what everybody knows about now what NGS is, but the advantages are like it is a broad, rapid and parallel testing for all biomarkers of interest. And however, there are number of challenges which are faced when you are doing the NGS. Right now, there are no currently validated panels available for to detect these oncogenic mutations and the types of mutation within one test. Many testing labs do not have this technology. However, the costly specialized equipments are essential. So what are the paths? As I explained this slide, I will skip this. So why is it important to include MET exon 14 skipping? Because the accurate detection of MET exon 14 requires a well-designed approach to cover the diverse genomic events varying in size and position that lead to exon 14 skipping. So the hybrid capture method is the most adaptable method for the either to detect for the DNA or for the RNA approach. So we have to be very careful while using the commercial amplicon based NGS method, because it is not reliable for detecting the MET exon 14 due to its false negatives. So this is the panel which has been advised by the NCCN guidelines. Apart from the EGFR, ALK, ROS, BRAF, we need to have the MET exon 14 and the RET testing. So, and the as per the NCCN guidelines, we need to have the reports within the 10 to 14 working days of the biopsy report which is done. Also, the liquid biopsy is also one of the tests which is preferred, because if there is a shortage of tissue, because especially in lung, we can also do performed by the liquid biopsy testing. Of course, it has its own limitations because there is low variant allele frequency, it is highly fragmented because of the small base pair size, and it needs for test for standardization. But however, the concordance sometimes is limited between the liquid and tissue assays. So this is the by doing liquid biopsy and tissue testing, concordance is being heavily studied, and many studies show significant concordance which can be achieved between these two different types of assays. So I would like to thank Novartis because it has explored various large panel by using the ALK, BRAF, EGFR, ERBB2, KRAS, MAP2K, MET, and RAS, PIK3CA, ROS1, and TP53. And apart from that, fusions like NTRK, ALK, RET, and ROS1. As I mentioned, that MET exon 14 has to be looked at the DNA as well as the fusion level, because at the RNA level, because if there is a whole lot of exon 14 skipping, only it can be detected through the fusion that is at the RNA. Thank you so much.
Thank you, ma'am, for this great talk. Now, I like to invite Dr. Ulas Batra, sir. He is a senior medical oncologist practicing in New Delhi. Sir, to you now.
Thank you. And okay, here we go. Thank you, Dr. Anuradha, to set the floor set for me to speak about the unblocking the unmet need in MET exon 14 mutant non-small cell lung cancer. These are the disclaimers. And my first reactions when I first saw this talk about unblocking the MET exon pathway was like this. MET here is basically not about capmatinib and tepotinib and savolitinib and everything. MET exactly today and yesterday was, where did Vicky meet Katrina for the first time? And my subsequent reactions at that time, and please note the color combination red and red in the marriage occasion, was, didn't you know? I mean, at least I didn't know till around 7 days back that they were getting married together. Like I didn't know what about Vicky Kaushal and Katrina Kaif. I also didn't know that MET, I thought, just came a year or 2 years back. But that's the timeline of actually MET inhibition. MET as a gene was identified in 1984 or 1986. In 2005, the MET exon 14 splicing mutation basically was reported. In 2018, crizotinib was approved for MET exon 14 splicing. And in 2019, capmatinib and tepotinib really came in a big way and were approved for this mutation. So, I mean, that is where we all were. So, like we had, at least I had no clue about Vicky Kaushal and Katrina Kaif. I had no clue about what was happening in the MET space also till around recently, around 1 year back. And that's a thing which actually should be there for all of us, at least for me. Wake up. There is more to life in lung cancer that is actually been happening over there. So let's talk about MET14 alteration in lung cancer. I'll just like to tell you briefly that they are present in 3% of non-small cell lung cancer patients, mostly older females, former or current smokers. I'll come to that. But it is present in 20% of pulmonary sarcomatoid carcinomas, and that is something which is very, very important. So the moment you have a sarcomatoid carcinoma, we should definitely go and test for these mutations. Now, MET mutation, good or bad, it is a bad prognostic factor. If you have a MET positive tumor, they are associated actually with worse survival. You can see the purple curve over here, and you can see the gray curve on the below side, which basically says that an untreated MET exon 14 is associated with a worse survival. Now, what about immunotherapy? And as I open the slide, immunotherapy, Dr. Sevanti Lime suddenly appears on the screen. So maybe immunotherapy is synonymous with Dr. Sevanti Lime. But MET exon 14 also is associated with a poor response to immunotherapy, with a median PFS of 1.9 and a median overall survival of only 18.2 months. However, so immunotherapy doesn't work, generic chemotherapy doesn't work, but if you have a MET inhibition in any of the MET mutated stage 4 non-small cell lung cancer, your survival increases from 8.1 months to 24.6 months, which is absolutely fantastic. Now, the MET inhibitors are not one. MET inhibitors can be type 1A, type 1B, type 2 TKIs. It basically depends upon how they bind the ATP pocket in the active conformation or they bind it in the inactive conformation. But more importantly, if you say the IC50 for crizotinib, that is the type 1A MET blocker, is 22.5, and compare that with capmatinib, which is only 0.06. So basically, capmatinib is a very selective, highly potent MET blocker in its regular dosages. You are not alone. MET exon 14 alteration. The first thing to come actually was crizotinib. In fact, we have a paper in which we have given crizotinib to 4 or 5 patients, and this in the 001 trial showed an overall response rate of 35% with a median response rate of PFS of around 7.3. However, capmatinib does not cross the blood-brain barrier, and please remember the median PFS of 7.3 months actually over here. That brings me to the subject of today's trial, that is capmatinib. That was the geometry trial, a very complicated study design, in which you have 7 cohorts actually. I will be talking about the only the 2 cohorts to start with, that is the 4 cohorts, cohort number 4 and cohort number 5B. So easy, you have a MET exon 14 mutation detected, irrespective of MET copy gain number by a central RT-PCR, were given capmatinib 400 mg BD. Cohort 4 was the pre-treated, cohort 5B was the naive. So easy, you have cohort 4, which is pre-treated, cohort 5B, which is basically treatment naive. And this is a very important slide as far as I am concerned. It basically shows that females accounted for 60 to 65%, never smokers accounted for around 65%, adenocarcinoma in 80% of patients, brain metastasis in 15% of patients. What it also shows me actually is that 35% of males who are smokers, 35% of smokers and squamous cell carcinomas also will have a MET exon 14 splicing mutation. So we should definitely test for people, a male smoker, tendency is to not get an NGS done. But I think with in a squamous cell, so now that calls for one more extra point, that maybe we should do NGS in all our patients, except rather than looking only for females and all. And we have actually changed our practice from a single gene testing to a NGS for almost everyone. Now again, exon code, if you look at the cohort 4, you have an overall response rate of 40% with a disease control rate of 75%. But if you look at the cohort 5B, you have a 65% rate overall response rate and a disease control rate of 95%, which is absolutely fantastic for a first-time capmatinib like this. Again, the responses were rapid. If you can see over here, the responses were deep, and the duration of responses also was 9 months in cohort 4 and 14 months in cohort 5B. Compare this with the crizotinib data, which was only around 7 months, I guess. Again, very, very important point is that the tumor shrinkage by MET alterations, very important point is you can either detect the exon 14 splicing mutation by RT-PCR or by NGS, a high concordance rate. But if you have a exon 14 mutation detected, please treat them with capmatinib and all of them will have a fantastic report. Now, this was the 2020 data by Wolf et al. PFS of 6 months in second line setting and the PFS of 10 months in the first line setting was basically observed. Very, very importantly, capmatinib crosses the blood-brain barrier, which is, you can have a look at the lesions over here and you can have the lesions over here, which is absolutely fantastic. So intracranial disease control rate was also seen in 12 by 13 patients. This was the 2020 data. Now, what happened in 2021 data was that they presented in the ASCO 2021. Now, you had cohort 4 and cohort 5B. Now, they got expansion cohorts over here, cohort 6 and cohort 7 also over here. Now, what this basically showed was expansion cohort 7 was again a response rate of 67.9 and 65.6 with a disease control rate of 96.4 versus 100%. The moment I say disease control rate of 96, 97, 100, the only picture which is coming onto my screen is Nirmal Roth's. So probably Nirmal Roth is also used to getting 100% marks. We are on this normal rate of 67, 66% actually. Even in second line, you have a 51% and 40.6% people who are responding in second and third lines also, which is again very, very important. And this is absolutely fantastic. A 20.8 months OS in the first line and 13.6 months in the second line was actually observed over here. So to conclude, overall response rate of 68%, disease control rate of 97%, durable responses, deep responses, rapid responses, a median overall survival of 20.8 months in the first line. And definitely this is for Novartis and Met, all our patients who have an exon 14 splicing mutation. This calls for a celebration. But celebrations are not the only thing over here, because Novartis is not alone in getting capmatinib. And here is where my sponsored session talk ends. And I'll talk about more about science now. You have 3 more inhibitors, tepotinib, and savolitinib and capmatinib, obviously. And here, Vision trial showed basically that MET exon 14 was detected by plasma. And what they basically did was that again they found out that the median PFS was 9.5 months, and the median in the tissue biopsy it was 10.8, it was 12.2. So if you have a lot of MET inhibitors, how do you decide? So if there are people who are awake still, I think I would just like to show here. I think crizotinib basically goes out of equation with a low response rate with everything. I think crizotinib goes out of the thing. Capmatinib in the first line has the highest median PFS rate of 10.8 and an overall survival of 20.8 with a response rate of 65.6%. Tepotinib works the same whether it is the first line or second line. Savolitinib almost by the same. So as far as I am concerned, capmatinib has the highest response rate, the good PFS in 10.8, large number of patients, and the only trial to show some kind of OS data in the first line. Now, why should MET inhibitor? Second question which comes is that 2 more questions I'll ask. One is what MET inhibitor? Capmatinib is available. We should use that. Second is what about the role of immunotherapy in MET exon 14 non-small cell lung cancer patients? Again, when I say immunotherapy, Nirmal Roth's screen lights up. So maybe they are the guys for immunotherapy. But if you look at the ICI outcomes, which I have just told you on the left side, you have a response rate of 17%, PFS of 1.9 months. PDL1 was not predictive, low TMB. If you compare that to the geometry data, you basically have a PFS of around 12 months and with a very good OS advantage. So probably for me, immunotherapy also doesn't work. Again, last 3 slides, please. This is just a comparison of if somebody has got a PDL1 more than 50%, you have an overall response rate of 44.8.
We need to conclude.
1 minute, just 1 minute. And capmatinib has 68% of response rate. So probably a better overall response rate, similar PFS. The efficacy of capmatinib is better when given in first line. So maybe probably we should actually go ahead with the first line. Side effects were by and large okay. One side effect which is there is increasing creatinine. Don't bother about that because it is basically caused by the inhibitor of renal MATE transporters. Forget my experience. Somebody is going to speak about that. So in my last concluding slide, exon 14 splicing mutation should be tested by either PCR or NGS, RNA-based NGS. Capmatinib is a potent MET TKI inhibitor. And the journey of MET in non-small cell lung cancer is basically from Vicky Kaushal to when they met to so glad that they met and, we didn't get invited to the wedding. With that, maybe Dr. Sevanti went for the wedding over there. So with that, thank you. Thank you for giving me an extra minute to show Vicky Kaushal's photograph and hand it back to the organizers. Thank you.
Thank you so much, sir.
Ullas sir, I have a question for you, Vijay here. Would your choice change if it is MET amplified? No mutation,
yes.
MET amplified.
Yeah. So MET amplification, the data just came. First of all, we don't know what is the level of MET amplification that we're talking about. Whether we're talking about 6, because tepotinib in the Vision trial by liquid biopsy took it more than 2.5. So for more than 6 or more than 10, I will not really use in the first line. In the second line, I would give capmatinib. No doubt about that. But not in the first line.
Okay.
Thank you, sir. For next, it is a case discussion. I like to invite Dr. Nirmal Raut. He is an oncologist from Mumbai. To you, sir. I would like to please be short and to conclude in time.
Yeah. Can you see my slides?
Yes, Nirmal, you're audible and you're visible.
Yeah. Okay. So I'm now going to present the real world data of MET amplification. This was a 52-year-old female who was a never smoker, evaluated for dyspnea and cough. Chest X-ray suggestive of left pleural effusion. Pleural fluid cytology was suggestive of metastatic adeno-CA. Whole body CT scan was suggestive of isolated pleural effusion, no visceral mets. Next generation sequencing on the pleural fluid cell block showed MET copy number of 3.10 with respect to 2.0 for wild type cells, suggestive of MET amplification. So this was the scans of the patient. There was this pleural effusion, which was the only site. So isolated pleural effusion and this MET exon copy number of 3.02. Yeah. So with this, how would you treat this patient with chemotherapy, with immunotherapy plus or minus chemotherapy or targeted therapy? What we did was we started this patient on crizotinib. Crizotinib was started in the dose of 250 milligrams per day, twice a day for 2 months. But the PET scan showed new development of ascites and peritoneal mets. So crizotinib clearly did not work. So we changed this patient to chemotherapy, which consists of pemetrexed and carboplatin, which was given for 6 cycles, and there was some partial response. So what next? What next would you do? Would you observe this patient? Would you give pemetrexed maintenance for 1 year, or would you give targeted therapy for MET inhibitor? Okay, so as Dr. Anuradha pointed out this c-MET pathway, so we have different c-MET inhibitors, class 1, class 2, which Dr. Ullas did alluded to. So we chose capmatinib based on the IC50 value, which was the least for this. So IC50 value of capmatinib is 0.6 as compared to others, which is greater, like crizotinib is 22.5, cabozantinib is 7.2, tepotinib is 3.0, and savolitinib is 2.1, while capmatinib is 0.6. So we wrote to Novartis for the compassionate access program, and they were compassionate enough to give us the drugs. And with that, capmatinib was started 400 mg BD. And you can see this PET scans, which show the pleural effusion is gone. The ascites and peritoneal mets have also gone. There was bilateral pedal edema, which was the only side effect that this patient had, but it does not require any dose reduction or any dose interruption. So these were the scans of the patient, which showed that the pleural effusion has completely gone, and even the peritoneal and the ascites has also completely gone. So this a case of carcinoma lung, which was post chemotherapy and target therapy, treated with capmatinib, where this patient was showing no evidence of disease. So, this is a real life incidence where crizotinib has not worked. Even the chemotherapy had shown a partial response, but this patient was put on a maintenance capmatinib, and that is why this patient showed very good response to targeted therapy. This was another case. This was published in the IGMPO as a case report, where EGFR and MET were together present de novo at the same time as EGFR. So this patient was started on EGFR inhibitors when EGFR was detected by PCR, and this patient was started on geftinib. So after 15 days, the patient had classical dyspnea, and so we got her admitted, and our protocol is to do NGS at all the patients at baseline. So when this patient came to us, we had sent her NGS for at baseline, and we found that in 15 days we got the NGS report, which showed that EGFR and MET were coexisting. So there was this unique case where EGFR and MET exon 14 were coexisting in the same case. And then so as you can see in the scans initially this was at baseline. Then after 15 days with geftinib, there was disease progression. And then after 3 months of geftinib and capmatinib, this patient had regression. And this patient also had some paranoia and skin rash, which was because of geftinib. So we converted this patient to osimertinib plus capmatinib, and this patient is still working well. Yeah, so, with NGS now available to us, choosing the therapy has become as easy as laying some chess As you can see, when you have exon 19 or 21 mutation, you put forward geftinib. When you have T790, you put forward osimertinib. And when you have a MET amplification, you put forward osimertinib plus capmatinib. Yeah. Okay. So with that, I would like to end my real life experience with MET inhibitors, and over to the presenters.
Thank you, sir, for a short presentation. Next, I would like to invite Dr. Sevanti Limay, ma'am, Senior Medical Oncologist from Mumbai, for her next case. Over to you, ma'am.
Hi, good evening. So, from जब we met to the Met in Katrina and Vicky Kaushal, and I see all the guys are totally burnt, ashes, ashes, ashes. So here I am talking about the real men. Just a compliment to the two speakers. Very well done. I just have a patient to share, just to reiterate the same story. So basically, a 60-year-old Asian female, non-smoker, presents with persistent cough, found to have a left lung mass. Chest CT also confirms that, adenocarcinoma lung, metastatic disease on abdominal CT scan, and brain MRI also shows multiple metastases. Chest X-ray, again here you can see the lesion, and chest CT, you can see the lesion as well. So, question, how do we do the testing? Do we do our oncogenic drivers? She's a non-smoker, and with lung cancer, advanced lung cancer, do you do the NGS or do you do your oncogenic drivers up front? Do you do it at progression? And how do you treat your patients? We're just trying to drive home the message about how to choose therapy in first line setting. So yes, would you start the patient on therapy right away? Would you give chemotherapy? Would you add the immune checkpoint inhibitor in the first go after the initial driver mutation testing? What all do you test for? So a lot of us are testing EGFR ALK-ROS. Some of us are testing EGFR ALK-ROS BRAF and PD-L1, and some of us are doing the entire NGS panel. Which category do you fall in, and how do you decide your patients? So just mentioning my style here, I actually, whatever the patient comes in with at the time of initial review or evaluation, immediately preserve the tissue, send in for comprehensive genomic profiling, pretty much to conserve tissue and not have to go back for retesting. This is the classic prototype that you can get. This is an Asian female non-smoker. Better to get your answer regarding driver mutation right up front, because we know immune checkpoint inhibitors don't work that well in driver mutation positive patients. So I don't limit myself to EGFR, ALK-ROS, I go beyond, and that testing needs to happen upfront, because if you don't do it upfront, you'll run out of tissue, and that's when you'll not be able to catch a lot of the stuff that you should be catching. So does broad panel molecular testing happen at your treatment center, and do you want to get tissue, or are you okay with liquid biopsies? And to that, I would say always attempt to get enough tissue, because PD-L1 needs to be done as well. And if you're suspecting driver mutation positive patient and you don't have tissue, PD-L1 to me becomes secondary, because if this is a classic prototype of a driver mutation positive patient, then I'm going to go after the driver. And in that situation, even if the PD-L1 comes in very high, I don't believe that and don't act on that. So broad panel molecular testing for this patient reveals a MET exon 14 non-small cell lung cancer, adenocarcinoma, and the PD-L1 expression is above 50%. Based on the current practice, do you think the diagnosis is correct? And do you think, the treatment should be a MET inhibitor, or do you think the treatment should be other systemic treatments like chemotherapy plus immunotherapy, or immunotherapy alone? So if this patient, so this patient goes on a MET inhibitor. Now, which MET inhibitor would you prefer? You just heard Dr. Ullas Batra with his great speech, and which MET inhibitor would we choose out of these 4 that are enlisted here? And from the very nice diagram that he showed, it was, of course, the response rates were highest with capmatinib. And this is a slide that just reiterates the same question, the options that we have. And today we have capmatinib with the highest response. And the type 2 TKIs, because we just saw cabozantinib launched, I also want to put in a word here that these are actually not specific. And so you need to look at specific wherein MET exon 14 activity is going to be there. And these are the 4 that you are going to juggle from. And crizotinib at this juncture falls short significantly of the expected response from the MET inhibitor vis-a-vis capmatinib. And you can easily see it in this bar graph that capmatinib's response rate is in the range of 64%, which was described by Ullas just a few minutes ago. And when you look at the outcomes in the Berk study, you can easily see here that the first-line utilization of capmatinib gave the highest response rate of 67.9%, versus if you had second line, it was 51.6%, and third line, 40%. So the responses do go down. The time is to attack in first line, and updated efficacy is also shown here, where the duration of responses are obviously the longest in patients who were given the drug first line, versus pre-treated patients where you still do get benefit, and the benefits are significant, but not as much as you would expect if you were giving it first line. And the median overall survival that we have here, again, in the treatment naive group was significant at 20.8 months versus 13.6 months in pre-treated patients as seen in cohort 4. Again, response rates more prominent, and in the vision study also we have tepotinib, and so Ullas discussed about this as well, but the response rates are just lesser than what we have seen for capmatinib. So till now, that's our drug to go. And intracranial efficacy in this slide shows objective response rates that are significant for 47.8% of patients, and disease control rate of 73.9. Just underlining that point, because my patient has brain metastasis, and whether or not this would be a patient to benefit from capmatinib. So you just saw significant responses even in the brain. So just talking about what are the barriers to current testing processes in non-small cell lung cancer patients in your practice. A lot of us are not aware that we need to do adequate biomarker testing right in the first line. A lot of us are also implementing Keynote 189 in driver mutation negative patients, but not looking enough for the driver mutation, even in classic prototype, believing PD-L1 that is high, PD-L1 percentage that is high. And let's say we tested for 4 driver mutations and those driver mutations came back negative. Even in a classic prototype, if the PD-L1 is high, I've done this earlier, wherein the initial testing did not show anything, PD-L1 high, gave the Keynote 189 regimen only to retest later and find out that the patient had something. And that's why failed the Keynote 189 sooner than other patients. One of the classic things that I have...
sorry to interrupt, ma'am. We've run out of time. So if you could conclude.
Okay. Classic driver mutations that are seen, that are missed out, are one of them is MET exon 14. And one of the reasons is the testing method should be perfected. RNA-based testing methods are considered to be even more specific. Liquid biopsy-based testing has been shown to pick up Metexon 14, and that is also something that can be utilized with classic responses here in this study with 81% response. Drugs are very well tolerated as was just shown. So my patient goes on to receive capmatinib 400 BD and has minimal side effect with minimal rash, fatigue, peripheral edema, and continued the treatment for over 6 months with significant response and benefit. Would you have considered a MET inhibitor versus chemo IO for this patient? And as shown by Dr. Ullas Batra, the responses with chemotherapy, immunotherapy, combination, crizotinib, all of those are inferior to what we see with capmatinib in this patient population. And so one should wait for NGS test results before implementation of immune checkpoint inhibitors in a classic prototype of driver mutation positive patient, and ignore the PD-L1 for these patients. That's what I would appeal, and do the broad panel testing upfront if at all possible. With that, thank you for the opportunity. I hope you found my case interesting, but the most interesting discussion is the Jab We Met discussion. Thank you.
Thank you, madam, so much for the great talk. With this, we move on to the next session. So I would like to call on upon our next speaker, Dr. Prahlad from Tata Memorial Center, Mumbai, for his talk on the role of nicotine patches and e-cigarettes in smoking cessation.
Good evening, everyone. Today I would like to discuss the article which was published in Lancet, nicotine patches used in combination with e-cigarettes with and without nicotine for smoking cessation. This was published in Lancet last year. This study was done in New Zealand National Institute for Health. So coming to the background, nicotine replacement therapy helps reduce the nicotine withdrawal symptoms of people who quit smoking. However, no NRT available matches the nicotine concentrations and rapid delivery achieved with the smoking. E-cigarette should be offered as one of the main adjunct smoking cessation strategies for those people who want to quit the smoking. The Cochrane review of e-cigarettes for smoking cessation showed that nicotine e-cigarettes significantly increased the smoking abstinence at 6 months compared with nicotine-free cigarettes. Although absolute quit rates were low, 9% versus 4%. And this was the first trial to investigate the effectiveness and safety of combining nicotine patches and second generation e-cigarettes on the smoking abstinence. Coming to the methods, this was a community-based study which was done in the New Zealand, and the study period was between March 2016 and November 2017, and the population taken was 18 years and above who smoked tobacco. The amount was not specified, and who were motivated to quit in the next 2 weeks, and only one person per household was selected. And the design was parallel group pragmatic 3-arm randomized trial. And the exclusion criteria was pregnant breastfeeding women, history of prior e-cigarettes for smoking cessation for more than 1 week in the past year, or enrolled in any other program, and uncontrolled asthma or cardiovascular diseases. So methods were 1623 people were assessed for the eligibility, out of which 1124 people were taken and were randomized using stratified block randomization using 1:4:4 ratio. So there were 3 arms: nicotine patch, 21 milligram, that is a 24-hour patch. So 125 patients were there in this arm. And the second arm is the nicotine patch plus nicotine e-cigarette, where 500 patients were included. And the third arm was nicotine patches plus nicotine-free e-cigarette. The 499 patients were included. So along with this, the moderate intensity behavioral support was done once in a week for 6 weeks. And the 15 minutes of withdrawal-oriented sessions were taken on telephone calls. And the variability of plus or minus 10% nicotine concentration was acceptable. All data were collected telephonically, and for primary analysis, intention to treat approach was used, whereby participants with unknown smoking status were deemed to be smoking. So analysis was, the primary outcome was the continuous smoking abstinence 6 months after the agreed quit date. The abstinence were verified by the mainly using standardized exhaled carbon monoxide measurement by Bedford Smokerlyzer. Less than 9 parts per million were taken. The secondary outcomes were assessed at quit rate 1, 3, 6 and 12 months after the agreed quit date. These were the secondary outcomes: continuous abstinence, carbon monoxide verified at 12 months, 7-day point prevalent abstinence, relapse, self-reported treatment adherence, tobacco withdrawal symptoms and urge to smoke and urge to vape, self-reported weight, any concomitant medications were used, and other smoking cessation support or medication was ongoing, and the treatment crossover. So coming to the results, so out of the three groups, the patches plus nicotine e-cigarette, so this was the continuous CO verified quit rate at 6 months was 7% versus 2%. So which was the p-value was 0.05. So no significant difference in 6 month verified continuous abstinence rate between the patches plus nicotine e-cigarette and patches only group was observed. The p-value was 0.05. So coming to the next group, nicotine e-cigarette plus patches versus nicotine free e-cigarette plus patches. So the difference of the primary outcome CO verified quit rate at 6 months was 7% versus 4%, which was statistically significant. So coming to the adherence was high at the quit date. Almost 90% of the participants in all the three groups reported patch use, and 94% reported e-cigarette use, and 85% reported both products, but decreased over time. By 3 months, only 50% of the participants in all three groups were still using patches, while 67% were still using e-cigarette and 56% were still using their nicotine-free e-cigarette. In the e-cigarette groups, only 33% of the participants were using both of their allocated products at the 3 months. So initially adherence was high, coming by going by 3 months and 6 months, the adherence was slightly going down. So 18 serious adverse events were occurred in 16 people in the patches plus nicotine e-cigarette group, compared with the 27 events in the 22 people in the patches plus nicotine free e-cigarette group, and 4 events in the 3 people in the patches only group. So in the patches plus nicotine e-cigarette group, 2 life-threatening serious adverse events were reported, mainly 2 separate heart attacks in 1 participant. So coming to the follow-up, almost like 30% of the participants in each of the 2 e-cigarette groups and 42% in patch only group were lost to follow-up at the 6 months. So mainly people younger than 40 years and who had low level of education had a quite significant amount of follow-up. So coming to the discussion, this trial found that the combination of nicotine patch plus e-cigarette was superior to patch plus nicotine free e-cigarette for 6 months smoking abstinence among dependent smokers who are motivated to quit. So the main drawback of this study was the 1800 people were the sample size and only 1100 people were recruited, and it was small sample size than anticipated, so quit rates did not reach the significance. However, quit rates at 1 month and 3 months in the e-cigarette groups in the current study was almost twice those reported in the 2 earlier trials. Despite higher proportion of participants in the patch only group using the patch, 6 month absolute quit rates for only patch group were low, but similar to those observed in the over-the-counter nicotine replacement therapy. So this trial was on comparison with USA based trial, the abstinence at 6 months was high. Compared to the UK trial, the higher self-reported 6 months was almost like lower than the 35% in the e-cigarette and 25% in the patch group. So the strengths are broad entry criteria with similarity to real world. Weakness was it's the smaller than the sample size, and the funding was a big problem. So in summary, the patches and the e-cigarette is not sustained by most people trying to quit. So patches plus nicotine e-cigarette group can be used for smoking cessation, could result 3 to 700 per 100 more smokers quitting long term than with the monotherapy. So future e-cigarette trials should focus on their use alone or in combination with usual smoking cessation support, given issues with the differential loss to follow up. Thank you.
Thank you, Dr. Prahlad. Now we move on to the next talk by Dr. Sachin Khurana from Delhi on weekly osimertinib dosing prevents EGFR mutant tumor cells destined to home mouse lungs. Dr. Sachin, over to you.
Just allow me to share my screen. So is my screen visible?
Yes, sir, it's visible.
Okay, thank you. And I'll just full screen. Okay, so I'll be discussing this trial. This study, which was published in Translational Oncology by Ashwin et al. From Tata Memorial Hospital and ACTREC. And this is basically looking at weekly osimertinib dosing prevents EGFR mutant tumor cells destined to home mouse lungs. So I'm not able to move the slides actually. Yeah. So a bit of background. So we all know about ADAURA trial, which showed that osimertinib, when given as an adjuvant treatment in daily dosing in stage 1B to 3A lung cancer patients, adenocarcinoma patients who are EGFR mutant, has a significant disease-free survival benefit. So this experiment, this study was actually set to establish an appropriate preclinical orthotopic mouse model to extend the implications of ADAURA trial by studying effect of pre-treatment with erlotinib, osimertinib in weekly/daily dosing on homing of PC9 cell lines in mice lungs. So this was the design of this experiment. They used 30 immunodeficient mice and divided them into 5 groups. Two groups received erlotinib in daily and weekly doses as pre-treatment, and 2 groups received osimertinib in daily and weekly doses, and 1 was controlled. They then injected these mice with luciferase-stacked lung adenocarcinoma PC9 cell lines. This is basically a lung cancer cell line which has exon 19 deletion, to assess their homing to the lungs of these mice. So what they did was basically in the group receiving daily dosing, they pre-treated these mice with erlotinib or geftinib starting 3 days before injecting the cell line, and in those in the weekly arms they gave 2 weekly doses of either erlotinib or osimertinib before injecting the mice with the PC9 cell lines. After injecting, they assessed bioluminescence till day 18, starting from day 1 till day 18 at some predefined intervals. And what they noticed was that in both the osimertinib arm, that is both weekly as well as the daily arms, there was loss of bioluminescence. That means there was elimination of this homing of PC9 cell lines in the mice lungs starting from day 3 itself, in both the weekly as well as a daily arm of osimertinib. But on the contrary, in both the erlotinib arms, bioluminescence persisted till day 18 in the weekly erlotinib, and it persisted till day 3, then vanished, and then again reappeared on day 18. Basically suggesting emergence of resistance to erlotinib. So what the authors discussed in this paper was that this efficient clearance of PC9 cells from the lungs with osimertinib, it may be due to a delayed metabolism of osimertinib and also maximum bioavailability of osimertinib in tumor generation site and lungs. And also, as osimertinib has minimal first-pass metabolism, low clearance, and a high distribution volume in humans, this may possibly explain the efficacy of osimertinib in the weekly dosing group. So, authors concluded that EGFR TKI pre-treatment in patients can delay the onset of disease in those patients who are receiving osimertinib as adjuvant treatment post-resection of early stage tumors, and also in patients who have predisposition to EGFR mutant lung cancers harboring germline EGFR kinase domain mutations. And they also concluded that this low dose once a week osimertinib, if proven to be effective in the above mentioned setting in humans, will have lower toxicity, more affordability, more ease of administration, and also may delay or prevent acquired resistance. So I went back and looked into some early phase trials of osimertinib, and yes, osimertinib is quite a potent drug, as we can see from these IC50 values, which are quite low for osimertinib in both the PC9 cell lines as well as those cell lines which have a T790M mutation. And this is the graph for osimertinib 20 mg dosing, and we can see that even with 20 mg dosing, we can achieve a steady state plasma concentration. And also we saw some responses even in the 20 mg dosing in early phase trials of osimertinib, which can also be seen in this phase 1 trial of osimertinib published in NEJM. And we can see that the response rate, the overall response rates with even with 20 mg and 40 mg doses in those patients who have T790M mutations were not too bad, 59%. And the 80 mg dose was actually selected based on the 70% response rate in T790M mutation. So my take would be that definitely this experiment, this study is a useful and it presents some useful and interesting insights on osimertinib pharmacokinetics and dynamics. The results are encouraging, which suggest potential efficacy of weekly osimertinib, which may be due to its irreversible inhibition and the other reasons which the authors have mentioned. Definitely, if it can be translated, if this potential efficacy of weekly osimertinib can be translated in humans also, then definitely more patients will benefit. But whether these results can be translated in humans is actually yet to be seen. And it would also be interesting to see what will be the efficacy of intermittent or maybe weekly or maybe a lower dose of osimertinib in established tumors. This particular study was actually to see the homing of PC9 cell lines. So that setting is a bit different. But what will happen in established tumors, we don't know. Maybe further such experiments and studies will be able to find out. So that's all from my side. Thank you.
Thank you, sir. We'll now move on to the next talk, that is the role of aprepitant for cough and lung cancer by Dr. Ajay Kumar Singh, who is a consultant medical oncologist at Tata Memorial Center, Mumbai.
Thank you to Kumar Prabhasar and Vijay Patil sir for giving this opportunity. Now today we have discussed all advances in lung cancer from molecular this immunotherapy, target therapy. Now we'll again come back to our basic. So we already know that lung cancer is one of the most commonest cancer all over the world, and in lung cancer the chronic morbidities are cough, breathlessness, fatigue, and if you come to the cough, the prevalence varies from 40 to 70% in various observational studies, and out of these, more than 2/3 patients are having severe troublesome cough during their course of the disease. So cough not only having this giving you physical, but it also affects your psychological, social, and lead to even social isolation also. But till now there is no any effective treatment for cough. So this was a very unmet need in the lung cancer. So this study was conducted based on the background that aprepitant was already approved drug for nausea vomiting, which blocks the substance P activation of neurokinin 1 receptor, and this was also one of the mechanisms implicated in the cough, mainly in the central region. The substance P activation of neurokinin 1 receptor lead to this initiation of cough through the vagal neural C fibers, which was located in small airways of the lungs. And other than these these C-type fibers, there are other mechanisms also, the inflammatory cells in the airway, lymphocytes and macrophages. And in the central system, if you come, there is a nucleus tractus solitarius, where again there is a secretion of this substance P, and which leads to the activation of this neurokinin 1 pathway. And so from peripheral to central, there is the involvement of this neurokinin pathway, and based on this background, they evaluated the role of NK inhibitor like aprepitant in cough to control the symptom in lung cancer patients. Previously also these were attempted, but due to poor central action of the earlier molecule and the endpoint was not well defined, so it led to failure in controlling the cough. But now with the better viability of the aprepitant, which is having a central action, they conducted this study So this study was basically a randomized double-blind controlled trial and crossover trial in patients with lung cancer. And it was conducted at the Christie National Health Services Foundation Trust in Manchester, United Kingdom. So the main aim of this study was to assess the efficacy of the aprepitant to control the cough, and another is to evaluate the mechanism of this cough and how it suppresses the cough by assessing the vagal nerve tissue. And when we come to the primary endpoint, the first was to see the so over a period of time they found out some endpoints, and they included these endpoints to make the primary endpoint in this study. So one was the awake objective cough frequency, and another primary endpoint was the during sleep frequency and 24 hours frequency. This was the primary endpoint, and they kept the secondary endpoint as the patient's reported outcomes. And there were few validated scales, which includes a cough severity visual analog scale, Manchester cough in lung cancer scale, and for few also they have utilized EORCTC, but not for all patients. So basically there were 3 scales which were included in this secondary endpoint, which were reported by patient. And they included adult patients who were diagnosed with non-small cell lung cancer and had a bothersome cough for more than 4 weeks, and had a performance status of 0 to 2, and was willing to participate in the study, and had a few exclusion criteria also. And in that exclusion mainly was the patient who are having on treatment with drugs which may interact, or having some infection on antibiotic which may again interact with your results. So this was the basic study design of this trial, where they randomized patient in crossover design like study. So they initially randomized patients either on aprepitant or placebo. Then after a washout period, again they cross over the patient, and the vice versa, the respective group took either a placebo or aprepitant. So at baseline they assess the scores for 24 hours, and after randomization and taking treatment, again on day 3 they observed the patient for 24 hours, and again did all the scoring of the scale. And after 3-day washout period, again for day 7 to day 8 and 9 they given treatment, and from day 9 again they did the scoring, and final follow-up scoring they did at the day 13 and day 14. So this was the consult diagram. They included 20 patients as per their statistical method, and out of this only 1 patient was excluded because of he developed the respiratory tract infection, and remaining 19 patients completed the study. So when we come to the results, we see that the main primary 3 endpoints, awake cough frequency, sleep cough frequency, and 24-hour cough frequency. Out of these, the awake cough frequency and 24-hour cough frequency has shown a significant response to the aprepitant, including a significant P point. Only the sleep cough frequency was not significant, and it was due to large variation in the symptoms. And when we come to the other patient reported outcomes, again we can see the visual analog scale, MCLSCS scale, and EORTC all has shown a significant response, statistically significant response to the aprepitant. So these were the graphs. If you see for awake cough frequency and 24-hour cough frequency, you can see how the lines were going down with the aprepitant, and you can see the P value is also very significant. Only the non-significant value was during sleep, and you can see the way how was the variation. And last part was included in this study was the mechanism. So they took the guinea pig vagal nerve, and they given the substance P, and they shown, you can see how with the substance P there was a stimulation of the nerve, but when they treated that nerve with the substance this aprepitant, there was a complete blockage of the depolarization. So it also shown that it was acting on the nerves. And when we come to the adverse event, you can see there is hardly any adverse event, and it was none patient have developed any grade 3 or grade 4 side effects. So in conclusion, it was a positive study to show that in refractory cough, this aprepitant is one of the options. The limitation of this study was it was a very small study and the follow-up was very small, hardly 2 weeks. So these were the two more main limitations, and obviously it was a proof of concept study, so sample size was very small. Thank you.
Thank you, Ajay. Now we move on to our next session, which is a panel discussion on choosing the right venous access device in lung cancer patients. I would like to invite our moderator, Dr. Ullas Batra, a consultant medical oncologist from New Delhi. Sir, welcome you to this session, and you may invite the panelists. So you're not audible.
Thank you. Am I audible now?
Yes, sir.
Okay, great. And that's the first time in a long time that I have seen a session getting early. So congratulations to the organizers. And maybe if Dr. Rahul and Dr. Manish Jain agree, we can also say that we will put a PICC line for all patients with lung cancer and we can stop it right now. So Dr. Rahul and Dr. Manish sir agree?
Yeah, I can agree for that.
तो सर मतलब बोल देते हैं कि हर पेशेंट में पिक लाइन लगाएंगे, पहले पिक लाइन लगाएंगे, फिर बायोप्सी करेंगे, फिर कीमो देंगे, so that we can go even home earlier. Okay.
That's true.
So, but still we have to, discuss something about PICC line, choosing a right CVAD. And my first reactions, as I normally, whenever I see a topic, I normally have my first reactions. Most of them are crap. This is even more crap. This was like CVAD in a lung cancer masterclass. I mean, this is an out of syllabus question. I really thought, what are we doing in a, PICC lines and ports, what I thought in a breast cancer symposium or a colorectal, we have long infusional chemotherapies and maybe vesicants chemotherapy is absolutely okay. Then I thought maybe I'm in a wrong meeting. Then maybe, I got an invite for something else. But, there we are. And then I actually looked at the list of all the distinguished speakers. So I thought, Kumar is a nice guy. He wanted to invite me to the meeting. So he just have given me some topic to discuss. All the big topics have been taken off by the other biggies. So, Dr. Manish, I will start with your point. Venous access, this is something which we normally don't discuss. But it can actually dramatically affect a patient's ability to receive appropriate treatment. Do you think we need to discuss this topic more frequently, or what is your take on that? Is the topic timely? Is it relevant? Is it useful?
Yeah, I think we are not discussing something because we are increasing the length of our treatment times now. We are increasing it to 1 year, 2 year, and then we are not discussing something which is more important, that how to infuse it. If we do not have good access and if we do not develop good team to handle intravenous care, how are we going to use treatments which are going to be for such prolonged period? And most of the treatments are now becoming prolonged. So if with immunotherapies, with monoclonals, with so many things happening, everything is going to require an access. And we should discuss this more frequently. And I think Kumar has taken up the topic, and it really, when I joined oncology in 94, 95, we used to discuss PICC line, Groshong that time. But after that, I have never seen it happen in last 20 years.
Okay. So 94, 95 was the time I joined MBBS, sir. Okay, that's great. Dr. Rahul, what's your take on this?
I think it's a very pertinent topic, and we tick all these boxes which you made, and we know that without a venous access, we cannot proceed. So I think that is the stepping stone to our therapy. And more importantly, majority of our patients come routinely for, again, testing their blood, and every time they need to be pricked. So I think venous access is very, very important. Starting a venous access, maintaining it, taking care of it, and without that, we cannot give chemotherapy. So I think it's a very, very pertinent topic.
I think also very important, honestly, we always do counsel the patients for a breast cancer, for a PICC line, or a port, maybe colon. Lung cancer, it never actually it actually always escaped my attention. Till the time I actually did one of these classes topics, and I actually found out, one of my patients was getting immunotherapy at the thumb. And somebody was getting the lower limbs. And I was here like, somebody spending 2 lakh rupees of treatment on nivolumab. And why didn't we even discuss this? Probably it just skipped my mind. It was not useful. So just imagine a nivolumab, let's just think about lung cancer. Somebody gets up 6 cycles of GemCarb. You have by and large got 12 pricks at least for the infusion for the chemos. Add to it, you have blood sampling every time before that. That makes it 24. Some test before that guy must have done. That makes it 30. You have 24 sessions of nivolumab. That makes it 54. Some blood samplings in between, some samplings in between. That makes 68 to 70, man. I just got a prick last time. My daughter got a prick when she had a dengue, and I jumped out of my bed, and I just got a blood test, and it's painful. I mean, I think it's actually very relevant, and from there onwards, last 2-3 months, my perspective about a central venous line has changed. There are also medical legal issues. One patient had extravasation to one of the drugs, and patient comes to me with etoposide and arm like this. I actually don't want to see that patient now, and the patient also doesn't want to see me. So I think very relevant topic, very timely and very useful. I totally agree with you. Again, very, very important. 70% of patients who have got irritant vesicant chemotherapy got phlebitis. Very easy to say, put some thromboflob, thromboflob laga lo, hep gel laga lo, baraf ki sikai kar lo, and then you look the other way around. But just think if it's one of our relatives, it's a very distressing thing to be, poked in the cannula again and again. And 22% of people actually get extravasation. So I want to bring both of you, Dr. Rahul first. Extravasation in your setup, has it increased, decreased, changed more? Or how do you think it is?
No, it's very common and it is increasing because as the number of patients increase and the number of chemotherapies increase, especially in breast where we give dose-dense chemotherapy and we try to give weekly paclitaxels, the incidence increases. For the staff, it is very easy to probably say that this vein can be ignored and we go to the other. In breast, even more when we know this patient has undergone surgery and one arm cannot be used itself. So vesication is very, very common, and we see it once a patient has come for the next cycle and we see the arm is already having vesication, and we are probably helpless and looking for what you mentioned, maybe an extremity, a thumb or for an access. So very, very common and very worrisome actually, vesication.
Okay. Dr. Minish, sir, your comments?
The number is not that big, but because as we said that, the number of patients are increasing, what we are seeing is more frequent now. Earlier, the percentage was more. Now the percentage of vesication is low. But if a patient gets any extravasation, that leads to an ulcer, leads to delay in treatment, very expensive. Sometimes the patients are even following up with me for years to say that, this fibrosis is not going, these movements are restricted. There are difficult times. We cannot explain them that this extravasation was because of the chemotherapy. And every time, as you rightly said, for that patient, we have to really put our face on the other side and try and say something and go away. So I agree that, this kind of thing should never happen. Even for 1% patient, it should not happen. The number 22% is not that common with us. It is maybe 1-2% extravasation. But those extravasations, even in a port extravasation or a fractured port, have created big troubles for us. Sometimes, that has also created trouble. In fact, today morning I was seeing a patient whose port is a problem and the chemo got delayed. There is like bacteremia, central line related infections. These are things which we should avoid. Peripheral extravasation, this we should avoid. So we require training. We require more care. We require to put in more efforts to understand this topic.
I think more importantly, we need a change in mindset, sir. I mean, that's very, very important. I'll just give you an example. There was a patient of mine, 6 cycles of pemetrexed, 12 cycles of pemetrexed maintenance. She's got exon 20 insertion. And then she got CKD. So, we diagnosed CKD, we withheld her chemotherapy, we did all those things for her. Then the disease progressed. I also have applied for amivantamab compassionate access. So, all doing very, very good. In the meantime, I wanted to give her paclitaxel. I gave her packet Excel, a new sister, a new daycare effort, and she had an examination. Trust me, the patient forgot everything. And they came and fought with me so much, sir. I mean, I can't. I said, yeah, come on, I have done so much for you. I'm getting you 10 lakh rupees, Doug, free of cost or something. They just didn't bother, sir. Some new attendant came and started shouting at me that, and again, medico-legally, sir, and I also spoke to people, medico-legally, whether it is a sister who does a examination or whatever, it is a treating doctor actually who is liable.
Responsible.
So that's a very scary effect actually. And the very simple answer was to me, doctor, we have been with your treatment for last 1 year. If we can afford this much of treatment, then why didn't you counsel us for a PICC report? I was actually stumped. Very few times that I am actually lost for an answer, and I didn't have an answer to give to them. So I think it's a very important topic which we need to discuss even further. Not only in lung masterclass, we should discuss in breast masterclass, GI masterclass, head and neck masterclass, whatever masterclass, we should discuss that actually. So that's it over here. Now, these are the venous access devices that we have actually. We have a peripheral IV cannula. We have an ultrasound guided peripheral IV cannula. That's the same thing. We have midline catheters. We recently in our ICUs, they are actually putting midline catheters, central venous, a subclavian or a jugular vein. Then we have a PICC or a tunnel catheter or a port. So my question for you, both of you, sir, I'll start with Dr. Rahul, is how do you decide which chemotherapy, which venous access device to be put for which patient, sir?
So one is the duration of chemotherapy and the type of chemotherapy that we are going to give. If we have to give infusional chemotherapy like 5FU, we definitely require a PICC line or a port. We are very comfortable with the PICC line, so we go for that. Also, if the patient has a long-term chemotherapy, which is 2 weekly initially and then weekly, we definitely go for the PICC lines. And in case there are vesicants or irritants, we definitely go for the PICC line or the port. But if the patient has a monthly chemotherapy, probably a doxorubicin, which has to be given once a month or something like that, then we encourage them for a peripheral IV cannula. But yes, one most important thing is how the patient is going to manage the PICC line and how compliant he is in taking care of the PICC line.
I will come to that. The roadblocks I'm going to come to.
So that is what we think. Yeah.
Okay, so you basically think the duration of chemotherapy, the type of chemotherapy, the length of treatment that we're expecting is a major determining factors as far as your practice is concerned. Fantastic. Dr. Manish, sir?
Yeah, I think, what we are looking at is how long the treatment is going to be, what is the pH, osmolality, what is the vesicant, irritant, what we are going to use, how long we are going to do, how much is your intensity of treatment, whether the patient is motivated, whether the patient understands. See, when PICC line, we have to make sure that the patient appropriateness is also very important. Whether they're going to come up for regular flush, whether they're going to be accessible. Otherwise, port is a better choice if the flush is not going to be possible. A lot of our patients are from periphery. So in that situation, sometimes even PICC line care is not available with them at 100 kilometers or 200 kilometers from the city. So in those situations, we cannot put up this kind of PICC line. So then we motivate them for port. If the access is very good, if it is a male patient with a good access and we are going to require only 4, 6, 8 doses, then we don't even force them for a central line or anything. But if it is a female, chubby, fat lady, or lines are a problem on day one, then we don't wait too long for them to land up into trouble and then go for a port or PICC line. We try to motivate them as early as possible, so that that is discussed as a part of treatment cost itself. Most of at our place, most of the time it is port rather than PICC. But I think what we are trying to now change in last few months is going towards PICC. We were doing more port because that were more easy at our place.
So absolutely right, sir. I think this is how you decide. I think there are two questions that I ask myself before when a patient comes to me. The first question when I ask about myself is, does the patient need, okay, from the TMS they're asking. Okay, one thing is that the first thing that we are decide is a central venous access or not, a PICC line or a port, yes or not. If it is yes, then I decide about the PICC or port. And definitely, as both of you have said, the type of infusates, the duration of treatment, the intensity, the vascular integrity. Again, a personal anecdote. One of my own relatives was there, and I was giving a weekly Paclitaxel carbo. And again, you don't want to expose your own relatives to all these PICC lines and ports and everything. So I didn't give for 2-3 cycles. At the end of it, I had to put a PICC line port because the veins ran out of it. And again, as the problem with treating your own relatives, they came and told me, this is such a good thing, why didn't you do it earlier? So, doctors and especially relatives are difficult to treat at that time. Okay, this is what is shown over there. This is just the green is the appropriate, yellow is the neutral, inappropriate disagreement. So if you have a irritant or a vesicant infusion, PICC line goes green for everything. If you have a chemotherapy for duration for less than 15-30 days, then port really doesn't make a difference over there. Frequent phlebotomy, again, yes for the PICC line. Port is obviously a red for the phlebotomy actually. Again, to say most chemotherapy agents are either vesicants or irritants. You look at this list. I think if I had put this list at the beginning, and maybe BARD should do this, they should give a list of irritant and vesicant drugs to all the doctors. I think, and the list of medico-legal compensation which people have been provided, every doctor will put either a PICC line or a port actually. So this is here, one of the major issues which have been there is basically the duration. So Dr. Rahul, I wanted to ask you, how much, what is the maximum amount of PICC line? One thing which I came across from your point was that if you have a long duration, you would prefer a port, but if it's a short duration, chemotherapy, 4 months, 6 months, you will want a PICC. What's the maximum PICC line that you have actually used it for?
So majority of our PICC lines work for 6 months. We extended some PICC lines up till 8 to 9 months, but we have never gone beyond a year. So I think that is what we have.
Dr. Rahul, you have not gone beyond because you have not gone, the PICC line has not gone, the patient has not gone.
Yeah. So now all the three factors, either the chemotherapy has got over, or the majority of the time the PICC line has got infected or thrombosed.
So fair enough. All three of you have not gone beyond 6 months.
Yes.
Dr. Manish, sir?
See, tunnel catheter, the longest I have used Hickman for 3 years. But PICC line we have used mostly for up to 6-7 months, 5 months. That is what is the average. Most of the time after that it was either neither used, or most of the time we thought that it is now time to change or remove it. So there were certain issues like tracing issues, peripheral infection, suspected rigors. We did not really pursue it because it was easier to pull it out. So those kind of things happened. But most of the time we could pull it on for a few months easily. So
again, sir, very thankful to the pandemic of webinars, because in this one of these pandemic of webinars, I did a moderation like today for the CVAD. And my gut feeling again, and I'm the most guilty person in the venous access this thing today. I used to take it out in 6 months time and say, "Ki 6 months chalti hai," and port will go for 2-3 years. That was my first statement. But then I looked at the literature over here, and 4 guidelines actually have said that PICC lines can go for 12 to 34 months actually. Having said that, after that for ovarian cancer patients especially, because we give them Paclitaxel carbos and then we take the PICC line out. That's what I used to do. And then when the relapse comes, I used to call them again. There are 2 of my patients who have now gone beyond 12 to 15 months and there's absolutely no issues. Again, this was Journal of Venous Access Devices and they said PICC lines could be used for 100 to 300 days. This was again a study which basically says 250 patients, median dwell time was 184, but the range is from 15 to 1,384 days. Again, can be used again. So again, the zinc patients. So let me understand the barriers. So let me ask you, Dr. Manish first. Sir, in last 100 patients of chemotherapy that you have given across all cancers, how many of them you have counseled for PICC line, and how many or a port, and how many of them have actually got the things? And so let's say you say 100 patients, you do counseling in X, and finally the turnover rate is in how much, sir?
See, as I said, most of the time when we counsel, the patient agrees to it. It is never that we counsel and they don't agree.
सर आप मुझे
No.
सर आप मुझे सिखा दो काउंसिल कैसे करते हैं. My results are absolutely dismal, sir. बताइए सर.
No, because counseling we do it to the right patient and right kind of thing. So generally they don't disagree to it. The issue is not that. The issue is that our motivation for PICC line has been low, as I said, at our center. Port has been higher, and most of our patients, 80-90% of our patients are on port rather than PICC.
So,
but we are changing recently. We have started changing to PICC. We have got a very good interventional radiologist who is picking up PICC lines very well. So we are now changing for that.
So, sir, can I ask you, because I can see someone coming on the dais and asking me to stop another 2 minutes. How much time do we have, yeah?
Sir, 13 seconds only.
13 seconds only. Okay, so can I take 1 more minute, please? Okay, so Dr. Minish, what will help you in changing over from port to PICC, and what are your roadblocks?
No, my roadblock was only one, that we did not have that many staff to handle the dressings for PICC line. For port, we don't have to do that, and because our center is very busy, our nursing staff is very limited. PICC line was an issue because every time the patient comes for a dressing, we require staff.
Regular dressing and lack of trained people. That is what the one thing.
No,
for you.
trained people are there, but they
there
are
now.
limited number.
Okay, Dr. Rahul, what will help you changing from port to PICC?
No. So we have always been the PICC. So we've never been the port, and
so
we
what will make you shift from PICC to more PICC? Pickers.
Yeah. So being from the government institute, we have plenty of PICCs. We have plenty of manpower for changing and putting PICCs.
On a scale of 0 to 10, sir, how much will you rate your satisfaction? And forget it's a bad symposium. Let's have an honest conversation.
It's a 9.5 because it's a 9.5 and only half a mark, so that I know we're not all 100%. So and being from a teaching establishment, we train our residents also on those things.
And sir, so Dr. Rahul, last one before somebody comes over there and switches me off. Who does the PICC line insertions for you?
Yes, so initially we start putting PICC lines on our own, but over a time period, our nursing staff has been trained, so they are further disseminating this knowledge. So we feel that train the trainer and train further. So that is what we follow, and now we've got a good team who keeps passing this on as we go forward too.
So I can tell you, yes, sir.
When I started my career in oncology, I was the one who was putting PICC lines.
Wow.
So we used to have this. We used to have these Vinacats, which
Yes,
were
sir.
long catheters, which we used to put. I used to do it myself for all my patients. I was the resident at Bombay Hospital, and Hinduja used to do all these things. But then eventually we lost this because the
I
other
think that
things
was a
came up.
fantastic thing, sir. So we had a person to come up. 10 more seconds. We had a person to who used to come and do, and now we have nurses who are doing this. Our residents are not really doing it, but nurses doing it. Trust me, the best decision that we have taken, and the things have become very, very, very easy actually for us. And so I think a lot of times I think Bard has got association with I think this Placto, and they are doing dressings at home also. So I think that's very, very, very easy for us to manage. And I definitely think that we should actually put the PICC lines or a central venous access for everyone, because that's my last closing statement. Our team is only as strong as its weakest member. Even if your weakest member has an IV cannula or a new sister who has goofed up that, trust me, the patient will have a lot of complaints against us, and we will have a lot of face-saving issues with that. With this, thank you, Dr. Minish, and thank you, Dr. Rahul, for a fantastic deliberation. Thank you.
Thank you, sir, for the great
Thank you.
discussion. Now we move on to the next session, which is the lung cancer year-end review quiz for residents. And I will invite Dr. Ajay, who is the quiz master for today.
Can I attend?
Yes, sir, sure.
And if I lose, then what will happen? If I lose,
You have to pay the winner.
I'll ask Kumar.
Okay, so we are at the interesting session of today's day. Students are waiting for long. So the quiz will be includes 10 questions, and 30 seconds will be given for each question to answer. So it is a multiple choice based answer, and there is a one correct answer. So we'll start now. the quiz, all of you need to join all need to join virtually to answer the questions. We'll wait for 30 seconds so that everyone can join virtually. Should I start now? Okay, we'll start now. Here is the first question. Which of these scales was not included in cuff assessment in apprehended study in lung cancer? So there are 4 options, A, B, C, D. Go through the options and give one correct answer. Next question. The nicotine patch and e-liquid nicotine content of e-cigarette in the Lancet published study for smoking cessation using dual nicotine replacement therapy. The contents is the following. You need to choose the right and correct combination. Next, third question. Which of the following statements are true regarding Violet study? I'll give 10 seconds extra because the options are long. Next question. Which of the following statements are false regarding POT C study? Okay, next question. All of the following statements are true following checkmate 816 trial except next SWOG S1403 randomized control trial. All are true except okay, next question. Omalternib drug. False statement regarding this drug is next question. In phase 3 Japanese trial of adjuvant gefitini versus cisplatin and vinorelbine in stage 2 and 3, the following subset survived longer in gefitini arm. Next, this JO25567 phase 2 Japanese trial. All are true except coming to the last question. All are false except one. for the quiz now. We'll announce the winner on his personal mail, and we'll send the details of prize also on the mail only. Thank you.
Thank you all. Thank you, delegates who had come physically, faculties who had come physically. Thank you, the delegates and faculties which had come virtually. With this, we come to the end of today's session of the fifth year end review. So the day is closed, and please join us for dinner who are here physically. Thank you.